All right, well, let's just get started with the question. So this is a 14-year-old girl. She presents with fever, chills, a history of influenza 1 week ago. Now she's got cough and left-sided pleuritic chest pain. Her chest X-ray shows a left lower lobe pneumonia. Her blood cultures grow a gram-positive cocci in clusters, and it says click here. So you click there, and this pops up. Okay, I'll let you look at that for a second in color. Then what is the appropriate antibiotic to begin in this patient? Do you want to start oral amoxicillin clavulanic acid or augmentin, IV vancomycin, IV ceftriaxone, IV ampicillin, or IV vancomycin and piperacillin tazobactam? So what do y'all want to do? Go ahead and vote. Okay, so we'll slow down here and spend some time on this question. All right, so B as in boy is the right answer here, and let's go through why B as in boy is the right answer. All right, so let's look back at this patient. So she's 14, she had fever, chills, and history of flu a week ago. Okay, remember on that little practice test thing you did? Remember, and I talked about, I think I mentioned briefly in the review about if you've got a history of flu, what organism do you need to be worried about showing up? Staph aureus. Okay, so that's the first clue. The second clue is they say it's a gram-positive cocci in clusters. What's that? Staph aureus. What is this? Staph aureus. This picture is Staph aureus. So this is gram-positive cocci in clusters. Okay, grapes. A bunch of grapes. This is Staph aureus. Okay. So then the next thing is, okay, you have to figure out, okay, I need to treat Staph aureus here. So let me look at my choices. So for some of you, they said, okay, there's a positive blood culture, there's a bacteria growing in the blood, and let me ask you this. So let's say I give you a bacteria and it grows in your blood, I make it grow in your blood, and you've got pneumonia with it. Do you want me to treat you with an oral antibiotic? Probably not, unless it's a quinolone, and then you might. But this is pediatrics, right? And she's under 18, so we're not going to be using any quinolones here. So there's not any oral antibiotic that you're going to use to treat somebody with a bacteremia. Just don't pick it, okay? Cipro would work for someone older than 18, but not for Staph aureus. It would be good for gram-negative, all right? But this is not a good drug for a bacteremia. Now, does augmentin get staph? Yes. Okay, it gets staph, all right? So, but it's oral, and you're not going to use an oral antibiotic to treat someone with a positive blood culture. Okay, just don't do that. All right, some of you went for, let's see, 13% went for ceftriaxone because you said, well, this is pneumococcus. All right, and you were just confused. Clusters, they're in pairs. Okay, pneumococcus is a type of strep. It's Streptococcus pneumoniae. So it's a strep. It's going to be in pairs usually or short chains. So the other thing is on the boards, you really want to be careful of using ceftriaxone because they know if an ID person is writing this question, they know that if someone comes in for anything, they say they have a hangnail, you give ceftriaxone to them. Oh, they have a 99-degree fever. Let's give them some ceftriaxone. And so be very careful about trying to use using ceftriaxone unless you really need to use it, which there's obviously in pediatrics lots of times you're going to need it, but sometimes you definitely don't need antibiotics. So this time, though, ceftriaxone does not, and the other thing with ceftriaxone, it does not get staph at all, okay? They know y'all try to use it for everything. It works really good for pneumococcus. It works really good for gonorrhea, obviously, okay, but it does not get Staph aureus. It's not a Staph aureus drug. Some of you picked ampicillin, okay? So I don't know, you're thinking there's listeria maybe, or enterococcus, because that's about the only thing it's going to use, or maybe a strep, just some other run-of-the-mill strep. But this is Staph aureus, okay? And ampicillin does not get Staph aureus. And then some of you had no idea and said, I'm going to pick the shotgun. All right, and you said, well, or you said you knew it was staph, But maybe they've got something else, and there's only gram-positive coverage with Vanc, and I'm really worried that she's real sick, and she may have a gram-negative. All right. The test told you what she had. They gave you a positive blood culture. The key thing with board questions is, in infectious disease, you want to pick the least broad-spectrum antibiotic you can to get the one thing they tell you need to treat. Okay? So for like strep throat, you're not going to use ceftriaxone. Okay? You would just use penicillin because that's the drug of choice. So here, they told you this is staph, so vancomycin is fine. The problem is you added in this pip-tazo, which pretty much gets the huge shotgun out, and you've covered every possible bacteria there is now, but you didn't need to because they told you what the narrow range, what the smaller gun should be, okay? Now, some of you are upset because you were like, well, we shouldn't use Vanc unless you really need to because maybe this is just methicillin-sensitive staph, all right? And the problem is there's no coverage on here. There's nothing on here that is any better for methicillin-sensitive staph than vancomycin at this point. And what they're trying to tell you is that many of you, as many of you know, you see a ton of MRSA in your community, right? I mean, you see every skin infection that's coming in now is methicillin-resistant Staph aureus or MRSA. And so they know that you know that and that we're seeing a lot of community-acquired methicillin-resistant staph. And so the best choice probably is to start with that in someone who's sick. She's got a pneumonia. She had a history of flu, which is our key to be thinking about Staph aureus. And you got a positive blood culture. And on the gram stain, you see Staph aureus, okay, what looks like to be Staph aureus. So the best choice here is B as in boy, okay? So pretty good on that one, at least for 46% of you. Okay, so here's how we're going to break it down. We'll talk about gram-positive cocci, and then we'll go to some of the other ones after that. So with Staph aureus, I'll give you this kind of list here because these are patients on the test you need to be thinking about, could they have Staph aureus or not? Okay, could they have Staph aureus or not? So Impetigo, just run-of-the-mill community-acquired Impetigo. If they've got osteomyelitis, you want to think about Staph aureus. IV drugs users. If the patient's on dialysis, toxic shock syndrome, which we'll talk about in a second. And then these kind of interesting in pediatrics, which they like to pick on things that are interesting in pediatrics that other people don't see, is that kids with cyanotic congenital heart disease commonly, not commonly, but they're going to get a brain abscess, you're going to worry that it's due to Staph aureus. Shunt infections you're very familiar with, and then this last one, the history of recent flu and new onset pneumonia. Now, if that patient, if it wasn't methicillin resistant, then probably what they would have had as a choice is nafcillin or oxacillin, okay? That would have been an appropriate choice. I don't think on the test they'll make you choose between those two unless they're telling you somewhere in the history that, there's a lot of community-acquired methicillin-resistant staph, then no, you need to go for vancomycin as a choice. If they don't tell you about it at all, then probably they may give you nafcillin or oxacillin still, and that would be perfectly fine. That would be perfectly fine for methicillin-sensitive staph. All right, so here's classic Impetigo, right? Commonly what they'll do is show you a picture of a face and around the nose and mouth. That's the common pictures that they like to show. So here's some part of the body, I have no idea where, here, and then this is a knee. Okay, on the test for you, if they give you MRSA growing in the blood, or say it's Staph aureus and it sounds like it may be methicillin resistant, just pick vancomycin and you'll be right. Okay, they're not going to ask you about the newer drugs, linezolid and all that. So vancomycin is a drug of choice for the boards. Now I know for some of you it's controversial because in your center you may have some Staph aureus that's becoming resistant to Vanc. It's not going to be on the PEDS boards yet. It's not ready for prime time, okay? So they're not going to be asking you about visa or anything like that at this point in pediatrics. The key thing with Vanc is you need to aim for a trough now of 15 to 20. Okay, so the trough is higher than what we used to do because we are worried somewhat about this resistance going on. And remember, you measure it just before the 4th dose. Now, the key thing here is this Gent and rifampin business with Synergy. That is pretty much out. Okay, there's really good data in adults not to do it anymore. and it should be the same for kids. The only time we're going to use the synergy is in someone who's got an artificial valve, a prosthetic valve endocarditis. Then you're going to add the gent and rifampin for synergy for Staph aureus. Okay, we'll talk about synergy later with Listeria and Enterococcus, and it's still in and okay. But for MRSA in the blood, vancomycin is really the only thing you should be using for just a run-of-the-mill methicillin-resistant Staph aureus. Okay, Daptomycin is the newer kid on the block. It's not FDA approved, though, for kids less than 18, so they won't ask us about it. I don't think they'll ask you about it. For MRSA pneumonia, linezolid, there's really good data showing it's superior to vanc, but in all the guidelines that have come out, the 2005 pneumonia and then the latest 2011 MRSA guidelines, they said you could use linezolid or vancomycin for Staph aureus pneumonia. I don't think in peds are going to give us linezolid. I still think they'll give you vancomycin as the drug they want you to use. The key is if they have daptomycin on there, you need to know daptomycin you cannot use in pneumonia. You don't use daptomycin for pneumonia. So they may have it listed as a distractor and give you a 19-year-old, and you remember somewhere in the back of your head we talked about daptomycin. Don't use it for pneumonia. It does not work for pneumonia. Okay, here's all the places that staph can go in the body, or any kind of bacteremia can go in the body. And so we'll hit on some of these different areas as we go down through some of these other topics. So let's do another case here. Here's Boudreaux. It's a 4-year-old who presented 1 week ago with chickenpox. 1 day ago, he developed fever, sore throat, and chills. He's delirious on arrival. He presents to the emergency department with a blood pressure of 40 over palpable. He's got conjunctivitis, a red macular rash with desquamation of the palms. His PT is out at 20. His PTT is out at 100. His creatinine is 3, which is abnormal, obviously, for a 4-year-old. His platelet count is 20,000, which is very low. And blood cultures, they say, are growing some type of organism in 8 hours. What's the most likely diagnosis? Do you think he's got severe varicella sepsis? Think this is due to Epstein-Barr virus? Does he have toxic shock syndrome due to E. coli? Does he have toxic shock syndrome due to Strep Pneumonia? Or is it toxic shock syndrome due to Staph aureus? So what do you think? Go ahead and vote. Okay, good. So D and E are both very good choices here. Now here's the question. So obviously one of these is right and one of these is wrong. Okay. And so here's where you have to figure out where maybe you can figure this out or maybe you can't. All right. So the first thing is the kid has chickenpox, right? All right. So think about chickenpox for a second. Those of you who've never seen it, think of the pictures that you've seen in the books about it. And remember, it's all these lesions, right? And what do kids do with the lesions? They scratch. Okay. So then think of something that might be on the skin that might make them sick very, very fast or spread very rapidly. And what do you think about? Okay, like a strep, maybe staph too. So some of you are thinking, well, it could be either one. Doesn't make it, what's the difference here? The difference is it's almost always due to strep with the chickenpox deal. Okay? The other thing is they tell you the blood culture is growing. That only happens with one of these, the strep. So 2 things here tell me it's strep, the chickenpox history and that the blood culture is growing. Okay, Staph aureus, we're going to see this with toxic shock. It's going to be, we still see it with tampons, and that was a classic presentation back in the 80s and 90s when we were seeing it, was you can still see it today. So they may give you a menstruating teenager who comes in with toxic shock. That's going to be due to staph, and she's not going to be growing it in her blood culture, okay? And it's due to a foreign body. So here's a tampon as a foreign body. Or maybe a surgery patient who has something implanted in them, and so it's a foreign body. So the foreign body deal is going to cause staph toxic shock. Our skin-related infection is going to be strep toxic shock. So this is strep. So D as in dog is the right answer here, okay? So toxic shock syndrome here, and the difficult thing about toxic shock is figuring out, it's not like they don't walk in on their forehead, it doesn't say toxic shock syndrome, right? And so all you see, initially you're looking at the kid on the test, and they've got fever, and they've got hypotension. you're like, okay, they've got sepsis, okay, or septic shock or something like that going on. Then you need to look and see, is there a rash? So they have a rash and say, well, maybe this is Rocky Mountain spotted fever. And then you need to look and see, is there multi-organ involvement? And commonly what they'll do is they'll give you bone marrow, so they have like a low white count or bad anemia or a low platelet count. They'll give you mucous membrane changes. They'll give you renal disease. So this kid's creatinine was 3. They may give you your liver function tests that are way out, like the PT. He knows the PT is way out. They may have diarrhea, so you get the GI stuff. They may have muscular aches and pains or rhabdo, or they may have CNS changes. So they need to have at least 3 different organ systems involved with the rash that usually desquamates, but that's late usually. And the specific definition says you have to have serology for Rocky Mountain leptomeasles, which obviously they're not going to give you that on the test. So if there's no geography in the question or anything, and you've got all this going on with this rash, and they have desquamation, you're going to be thinking, okay, this is toxic shock syndrome. And it's on the test situation, it's hard to figure out because it's easy right now because we're talking about it, but once you take away the context, it looks like any kid who's sick. So you have to put the pieces together here. So this is a hard one, and they like to put it on the test to make sure that you can figure this one out. So this could be the girl who's with tampon use, or could be a kid who went to surgery and had some kind of implantable device put in or something. And so just be aware that toxic shock can be those 2 different ways, the way they present. It'll look like this, same scenario, but just the presentation will be different of what caused it. So post-surgical, you got to go in and take out the surgical device. The strep, which was the answer to that question, is also associated with toxic shock syndrome. The menstruation is associated with staph. The blood culture is usually positive in strep, usually negative in staph. Now treatment, if it's staph, you're going to use oxacillin, bank if you're thinking MRSA, and then you add clindamycin plus or minus IVIG. For strep, it's IV pen, again to kill strep, and then the clindamycin. Now the clinda's here for an interesting reason. There's 2 reasons why we're adding the clinda. One is because, particularly with strep, penicillin will kill rapidly dividing strep really easily. Okay, so penicillin will kill the rapidly dividing strep. But down in the tissues, there's strep that are just kind of sitting there, and the penicillin is not going to be able to get them very well. The clindamycin will get those kind of dormant strep. The other thing is clindamycin has an antitoxin. Okay, it actually has an antitoxin effect. So the strep and the staph are producing toxins that the clindamycin actually has an effect on as well. Many people add the IVIG just because it appears in some studies to be helpful. Again, this is a big, immune thing going on here as well with this, and so somehow the IVIG appears to be helpful. If there's any evidence of necrotizing fasciitis, remember you need to debride the patient, get them to surgery if you can. All right, so this is just some bullous staph. So this is staph here in a little kid with these bullous lesions. So remember staph. So this is just kind of the run-of-the-mill staph that you are seeing in clinic all the time with boils and skin infections. You may have a kid come back in with recurrent boils, and then you're thinking, okay, they're probably colonized in their nose or some other body area with Staph aureus, and that's probably what's going on here, particularly with MRSA. You see that. If you think MRSA is going on as a cause of the boils or skin infections, which in general for community-acquired infections now everyone is thinking that, so always think about MRSA as a cause of community-acquired staph infection. You're going to look on the test for a couple of drugs. Clindamycin, people use, trimethoprim sulfa, doxy, or linezolid, which would be the last choice probably, at least in pediatrics. It's more likely they're going to give you Bactrim as a choice, trimethoprim sulfa, or clindamycin. And if you're worried, like if it's Impetigo, well, maybe strep is involved too, then it depends on what you're using. You need something that covers strep too. So clindamycin will cover strep and staph, or linezolid. If you're going to use Bactrim or tetracycline or doxycycline, you need to add amoxicillin because these two, trimethoprim sulfa, tetracycline, doxy, don't cover strep real well. So you'd have amoxicillin added to it. If you're having to put them in the hospital because of their cellulitis, you're going to use IV vancomycin. Again, MRSA, use IV Vanc. Okay, Staph Epidermidis, you're all very familiar with, particularly in your NICU babies. So the babies in the NICU, that's the one we worry about there. It's also, remember, the most common cause of catheter-related bacteremia. So if the kid has got chemo going and they've got a port, you worry about the Staph Epi being in there. If the child's not ill and there's only one blood culture positive for Staph Epi, for the most part, we can consider a contaminant. So they classically will give you a 4 or 5-year-old kid who came in with a high fever, got a blood culture, and it comes back in a day or two, and as they say, it's Staph Epi. And you call the kid, and the kid's running around and fine. And so you just generally ignore those. The one time you don't is if the kid's ill, obviously, or if it's a NICU baby. If it's a NICU baby, you're pretty much going to have to consider it as real until proven otherwise, because that's the bacteria they're very likely to get is Staph Epi. Again, treatment is vancomycin. Unless they tell you this is some rare Staph Epi now that's sensitive, otherwise you're just going to use vancomycin. All right, Strep Pneumo, another one. It's always on the boards now mainly because of our concern with meningitis, right? So everyone here hopefully knows for empiric meningitis treatment, we're using vancomycin plus a third generation. So vancomycin plus a third generation until we get our sensitivities known on the Strep Pneumo, if it grows Strep Pneumo. So in general, we don't know what's causing the meningitis, and so we're going to use Vanc and Rocephin, or Vanc and Clafuran, cefotaxime or ceftriaxone with the vancomycin, because there is resistance now with Strep Pneumo to ceftriaxone and cefotaxime. With pneumonias right now, everything's good. So you're pretty much okay using the ceftriaxone, cefotaxime, so that they're unlikely to ask you about that, because pretty much you can get high enough levels in the lung, even with resistance, that you're okay. All right, remember with Strep Pneumo, it's the most common bacterial cause. Now, I underline, if I could bold it, remember what's the most common cause of otitis media? Viruses, right? Okay, so don't be careful in the test question. You have to look at all the little words in there. So they may ask you, what's the most common cause of otitis media? Don't pick pneumococcus. It's going to be a virus. But they ask what's the most common bacterial cause of otitis media. It's still Strep Pneumo. Okay, now this may change over time as we're using the vaccine, but for now, for the boards, that's the correct answer. It's also the most common bacterial cause of bacteremia, meningitis, pneumonia in the United States. And you can get this occult bacteremia without a focus. And remember with this, I think I talk about, no, I don't. So with this one, remember, generally what happens is, again, the kid has high fever, you draw the blood culture, the blood culture comes back positive the next day, you call the house, the mom or dad says the kid's running around doing fine, and you don't do anything with it. Okay? This is very different, though, when we talk about H. flu in a few minutes. But for Strep Pneumo, occult bacteremia is common. You don't worry about it in general if the patient's doing well. Okay, otitis media. Remember, and this is pretty old now, so they're definitely going to ask you about using the higher dose amoxicillin for therapy. So if you're worried about that it's bacterial in particular, and you've tried the trial of not giving antibiotics, or they seem to be doing worse, then you're going to be definitely going to use amoxicillin at the higher dose. So you worry about increased resistance if on the test they give you a kid who's in daycare, which is every kid, right? Any kid who's been on recent antibiotics, which is every kid, any kid with your current otitis media, which is every kid, and then everyone less than 2. So, it's going to be the classic 18-month-old child who's come in who had seen some other doctor who kept putting them on antibiotics for their viral otitis media. Now they have a real otitis media, and they're going to ask you, are you worried about resistant pneumococcus? And the answer is yes. Okay. So use the higher dose amoxil. All right, group A strep is associated with all of these, and we'll go through some questions talking about these in a minute. The first thing I just want to hit is group A pharyngitis. Very important here is that you need to be careful about when you order rapid streps and throat cultures on the exam. So in general, for strep pharyngitis, you need to have fever, at least greater than 100. They commonly will describe cervical lymphadenopathy. They'll tell you there's exudates on the tonsils. And if that's all they have those three things, then you know you want to do a rapid strep, particularly if it's a kid, a younger kid, or a kid in grade school. You definitely want to go. So you go for the rapid strep first, and then the recommendations in pediatrics are you still go ahead and get a throat culture if it's negative. Okay, the reason is because the pretest probability that this is strep is very high. And so the reasoning is if the strep, even though the strep test may say it's negative, you still have a still high enough suspicion. You want to make absolutely sure it's not there, and so you do a culture. Okay, so recommendations are still for kids. We do a rapid strep followed by a throat culture if it's negative. Okay, or they do say in little quotes you can just do a throat culture first. So the test may give you they will either give you do a rapid strep or they'll give you a throat culture. Okay, or they'll say a rapid strep followed by a throat culture if negative. Okay, treatments PNV. If they're if for some reason you need to give if they want the shot, you can use IM shot. If they give you that as an option, that's perfectly fine too, obviously. If they're penallergic, erythromycin is still what they recommend. Now, what they're likely to do in the test question is give you these three things up here. They'll have fever, cervical lymphadenopathy. They'll show you a picture of this nasty throat, and they'll say the patient has runny nose. As soon as you see any URI symptoms in the question, do not order a rapid strep. Do not order a throat culture. Okay, this is not strep on the test. Do not order any testing. Say it's a cold. Okay, it's a cold. Now, I know what everyone does in real life. This isn't real life. This is the boards. Okay, there's very good data with this. You don't need to do this. Now, many of you say, well, I do it all the time, and I get strep back. Yeah, because they're colonized with it. It's not causing their disease right then, okay? So it's not causing disease. If they have a runny nose or they have a cough or they have URI symptoms, it's not strep on the test. Okay, it's not strep. Not strep in real life. It's not strep on the test. Okay. All right, strep again. This is in toddlers 1 to 3. So before that was the grade school kids. So this is younger, little toddler children. And they get this thing called streptococcosis or streptococcal fever. And this is where they get this thick, green nasal discharge. Okay? Low-grade fever, decreased feeding. They may complain of abdominal pain or have vomiting. And so treat it the same way. You're going to treat them. And generally, you can do this clinically if you've seen enough of these or have seen it. But in general, they commonly on the test will give you this scenario and then ask you, what do you think the most likely thing is? Okay? And you'll say, maybe it's streptococcosis or streptococcal fever, or I want to be worried about strep here. Okay. Scarlet fever, remember all scarlet fever is strep pharyngitis with a rash. Okay, so they have strep pharyngitis, and then they've made an exotoxin. The strep is making an exotoxin, and it's SPE A, B, C, or F. I wouldn't worry about these things, but it causes the rash. Okay, it's just a special kind of strep that causes the rash. Remember, it's sandpaper in quality. Sandpaper in quality. They'll have to describe it, and they may say it's a rough rash or granular feeling rash or something like that. Eventually we'll be on the, our technology will be good enough. You can rub the screen and feel the rash, or, But for now, they have to tell us what it feels like, or, Remember, it's prominent in the flexor skin creases, so, common here, flexor areas. And you're going to treat them the same as pharyngitis alone. So penicillin is still just fine. All right, so here's some classic pictures. So this one here on the left, so here I would have to tell you, it's a sandpaper feel, it's granular. So that's classic scarlet fever. This is in the antecubital fossa right here, so right in this area. And you see these lines here? These are called pastillas lines, P-A-S-T-I-A. So P-A-S-T-I-A, these are pathognomonic for strep. So if you see these, you have strep. Okay, they definitely have strep if you see this pastilla lines. Strawberry tongue. Okay, strawberry cervix looks like this too. All right, you see how the little white dots there? So this is strawberry tongue. Commonly in little kids, remember, the strep will be, or you'll see the rash really in like the diaper area. Very, very common where the diaper is sitting. They'll have a good rash with that. They have desquamation of the fingers commonly in the end. And this is just another kid who's got the classic sandpaper rash. All right. Erysipelas. So this is a strep infection that's gone deeper into layers of the skin and into the underlying connective tissue. The key finding here to make you think about erysipelas is the skin is tender. Okay, the skin hurts when you touch it. The other thing you'll see this very well demarcated line, and that's classic for strep. It'll actually, when you've seen it, and I'll show you a picture in a second, where you draw the line, you come back in 2 hours, and the rash is moved rapidly, okay? And it follows this line. It's like marching along. You can do these leading edge cultures. I don't think they'll ask you about that. The key thing is they want you to be able to identify this because you need to jump on this pretty quickly. So here's a kid right here. See where the rash was just to this little black line here, and now it's spread already past that, okay? If I ran my fingers along this rash, I could tell you exactly where it stopped and started. There'd be a very well line of demarcation, okay? Here's another kid, same thing. If you ran your finger along that, you would feel the demarcation line here. And this is a man's forehead, the same thing. And if you rubbed your hand along that, you could tell exactly where the rash started and stopped. It's classic for strep, classic for erysipelas. Treatment's the same, penicillin. Usually these require IV therapy. All right, necrotizing fasciitis. This is the flesh-eating bacteria that was in the news years and years ago. So this is cellulitis that's gone bad. You get severe pain and swelling, and usually you're going to have to do surgical debridement. And we commonly treat this the same as we do as toxic shock because there's strep really, really down far in the tissues. So we want the clindamycin again to help us there. And there's some data again with IVIG. But the key is penicillin and the clindamycin and debridement if you need it. Okay, so just briefly here, strep pyogenes are group A strep. Which of the following are true about group A beta hemolytic strep infection? Okay, so the first answer, A. Rheumatic fever occurs only from pharyngeal strains of group A strep. Is it B, post-strep glomerulonephritis can occur even with appropriate therapy? C, post-strep glomerulonephritis can occur from skin or pharyngeal strains. D, treatment of strep pharyngitis with penicillin prevents rheumatic fever. Or E, all of the above. So which of these do you think is true? Okay, good. So E is true here. And you need to know all 4 of these because these are common 4 questions they'll ask you. Okay? And you need to keep them straight in your head because I know it gets confusing. So for A, rheumatic fever occurs only from pharyngeal strains. That's true. So if you have just a skin infection with strep, you're not going to get rheumatic fever from that. Okay? You only can get rheumatic fever from a pharyngeal strain of strep. So A is true. B, post-strep glomerulonephritis can occur even with appropriate therapy. That's true. So even if we treat them with penicillin, you treat them within seconds of their strep infection, they still can get post-strep glomerulonephritis. Okay, it doesn't change that. They still can get that. C, post-strep glomerulonephritis can occur from skin or pharyngeal strains. That's true. So post-strep can occur from a skin infection or a throat. Rheumatic fever can only occur from a throat infection. And then D, treatment of strep pharyngitis with penicillin prevents rheumatic fever. And that's true. That's why we treat strep throat. Okay, so we're treating strep throat not to necessarily make the patient feel better. It will, maybe by a day. But the real reason is we want to prevent rheumatic fever. Okay, so treatment of strep pharyngitis prevents rheumatic fever. Okay, be sure you're familiar. You understand all 4 of those. If you're confused, come talk to me after the lecture. All right, Group B. Group B is in boy strep. So this is a major cause of newborn pneumonia, bacteremia, meningitis. And here's where the age of when things happen makes a huge difference in the presentation. And so you need to be familiar with these. So also it can cause UTIs in pregnant women. And then if the mom gets sick after delivering the baby, we worry about postpartum endometritis or bacteremia from group B strep. So early onset, okay, so early onset means up to 6 days of life, okay? So early onset was within the first up to 6 days of life. Usually most cases are going to be really quick, within an hour after delivery. So the baby's delivered, and then within an hour or two, these things start to happen. Commonly, you look back in the history, mom has some obstetrical complication occurring that occurred during labor. Commonly, this occurs more commonly in premature kids. And the way it presents, and this is important, this is what they like to hit on, is half of these kids will present with septicemia, the other 40% or so will present with pneumonia. These kids usually do not have meningitis, so this is different. So you need to remember early onset group B strep will present with just a bacteremia or sepsis or pneumonia. That's how it presents. I've listed the serotypes. Sometimes they can be really, angry, anal, or whatever, and ask you these. But just remember, it's early. That's how I remember this, early. So it's these types that occur early. 1, 2, 3, 4, or 5. Sorry, 1, 2, 3, 1A, 1B, 2, 3, and 5 are the most common. So things that are early numbers, smaller numbers. Okay. Case fatality rate 5 to 15%. Late onset is from day 7 to 3 months generally. The median time frame is almost like a month. It's almost always around a month or so. The kid's about a month of age. They've been home, they're doing great, and they show up in about a month of age, and they present with either a bacteremia without a focus, or they present with meningitis. So notice here, meningitis is the big one that jumps in. So we still have just the bacteremia, but now they have meningitis. This is also when you'll see things like osteomyelitis occur, or septic arthritis, okay? So this is the group that'll have this. This is serotype 3, so 3 months, serotype 3. Kind of remember that one. And that's the case fatality rate is lower, 2 to 6%. And then there's this late onset that somehow, who knows why, occurs way out at past 3 months. Usually this is going to be seen in a premature infant who had a history of or still has current IV lines. They're 4 months old, they're in the NICU, they still got lines, and they develop group B strep bacteremia. Okay, these kids do well, but you just need to jump on it and start them on therapy. So know when the meningitis occurs versus the pneumonia. Okay, that's important. All right, diagnosis, we do blood cultures. Remember, we have antigen detection. It can be useful, but on the test, you only want to use these antigens in case if the patient has gotten antibiotics. Otherwise, there's no reason to check the antigens. And use only serum or spinal fluid. Do not send a urine antigen. Okay, don't do it on the test. Okay. Treatment is penicillin or ampicillin plus gin initially. And then for pneumonia and sepsis, we usually finish out 10 days total of penicillin G. For meningitis, a minimum of 14 days of penicillin. And the septic arthritis, osteo, it's generally a longer course. All right, Group C and Group G. They commonly will present this on the test because they'll wonder if you know what they are. They very commonly cause pharyngitis. Okay, but remember, these do not cause rheumatic fever. They rarely can cause complications. If you find it, so generally what happens is you send the throat culture. It comes back as Group C or Group G strep. You call the kid. They're still having sore throat and fever, and you go, okay, let's treat them. Commonly you call them, and the kid's fine. Okay, but generally the recommendations are just go ahead and just treat them with penicillin. Okay. All right, Enterococcus. Mainly it's going to be a problem in our newborns. They cause UTIs, abdominal infections, bacteremia. And this is one of the weird ones in that you need to use ampicillin or penicillin again, or Vanc if they're pen allergic, which are not, newborns not going to be pen allergic probably, right? So generally it's ampicillin, penicillin. And here we still add the aminoglycoside if there's serious infection, okay, for serious infections. The other thing is, particularly in the NIs, you may have problems with resistant Enterococcus, and so you want to check sensitivities and just make sure that there's not a bad resistant Enterococcus there. I don't think they'll ask you about treatment. They may just ask you, should you check sensitivities? And it's rare enough that you should probably do it, especially if it's an NICU baby, just to make sure, or they tell you in the history that there's a lot of resistance in the hospital for whatever reason, then go ahead and check sensitivities. And most hospitals are going to do it anyway, so it's not something you have to ask. All right, switching gears from the cocci to the gram-positive rods. So let's talk about listeria. So again, this is a newborn thing. Okay, outside the newborn period, we're not going to generally see it in kids. Most of the kids are getting it from the mom. Okay. Now, there can be environmental sources, and so you may see it on pediatric exam in kids who have exposure to some of these things. So if they live on a sheep farm or a goat farm, or they have goat cheese, you know, or they've eaten uncooked hot dogs. That was an outbreak that we had not too long ago with uncooked hot dogs. And then the most recent last year, and now we have it again this year, is cantaloupes. Can't blame Colorado this year. They're from somewhere else. But cantaloupes may appear on the test because that was one of the biggest outbreaks we've had of listeria in a long, long time. So if they have cantaloupes, I'd be thinking about listeria. The other deal with this is the kid's really sick, and they tell you the blood culture is this diphteroid. Remember, most time we kind of blow that off. But if there's something in the history here that sounds suspicious, particularly a newborn, you're not going to blow it off. Don't pick it as contaminant. Continue the therapy until they've identified the organism completely. Okay, because the diphteroid commonly can turn out to be listeria once they get it further identified. The treatment is what we did with Enterococcus, so AMP or penicillin, plus or minus gentamicin for synergy in severe infections. All right, Corynebacteria, diphtheria. So remember, we vaccinate against this. So most of you have never seen a case. I've never seen a case. I've seen pictures of it. That's about it. And we were worried about this. Initially, we were seeing a few cases here in the States when the Soviet Union kind of decompensated, and so their healthcare system kind of fell apart in some parts of the provinces. And what happened is that we started seeing some immigrants come from this area who weren't immunized against diphtheria, and we were seeing a few cases here in the States. And we still occasionally see some. The deal with this is you have sore throat, you have a low-grade fever, so it's not a high fever, it's low grade, and they'll show you with this gray-white pharyngeal membrane. I'll show you a picture of that here in a second. What we worry about diphtheria, the big problem is the myocarditis, okay, the myocarditis that occurs with it. Okay, treatments, erythromycin, penicillin, and this is another where you give an antitoxin. So here, there's this grayish membrane back here. Everybody see that? Okay. All right, Arcanobacterium probably is going to appear on the test multiple times because the name's funny, and they may not know you know anything about it. It causes a pharyngitis very similar to Group A strep. The big thing about it was it got this huge press in the New England Journal and some of the other major journals because people had realized, were worried about it because they thought, well, this may be an emerging problem. And as it turns out, it really was much ado about nothing. It causes a pharyngitis very similar to Group A strep. It doesn't cause rheumatic fever, okay? And the treatment pretty much is the same. You know, erythromycin, tetracycline pen. Most kids who get this, if they ever had it and knew they had it, get over it, you know, without any treatment, okay? So it's not generally a big deal. It's probably there as a distractor more than anything. Okay, anthrax. So on the PEDS test, you know, years ago we would talk about anthrax, and it would be because it's some kid who lives on a farm and he works with sheep, all right? And that would be what was on the test. And so they'd be handling hides or wool. They get this painless papule. They get this painless ulcer. They get this painless black eschar that looks disgusting. It looks like it would hurt like heck, but it's painless. And then they get this induration and swelling. And that's what we would commonly see on the test with anthrax. Now, because of bioterrorism and the event that happened in 2003, or late 2002, 2003, with the outbreak from Florida and New York, and some of the first cases were in pediatrics. And so they may give you some history similar to that where there's been some kind of outbreak or something where someone thinks it's a bioterrorist event. Be thinking about that. And here's the old form. If they gave you an old question or they gave you a kid who works on a farm with sheep, this is painless. Okay, that looks like that would hurt. But and this is, you would think, well, maybe depending on where this is this is syphilis, okay, or is this anthrax? So if they gave you the sheep thing, hopefully, it's anthrax, not syphilis. But anyway, and this is your brain on anthrax, okay? So not good. This patient did not survive. If you didn't, okay. People laugh at the weirdest things. He didn't survive. Ha 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 ha. You know? Okay. It's kind of funny what we laugh at, isn't it? Okay. All right. Okay, for the test. This is important, I think. So a couple things with anthrax. So they tell you some bioterrorist thing has happened. You've identified some kids who've been exposed. And they say, okay, it's anthrax. It's anthrax. Maybe they'll just tell you it's anthrax. And there was a football game and it just got released or something. What you need to know is that this is not spread from person to person. Okay, so if you're admitting kids into the hospital, you don't have to worry about respiratory isolation. Okay, because they're not going to spread it from one kid to the other. Okay, now it's different if they said it was plague pneumonia or smallpox, and obviously you're going to need to put them in respiratory isolation. But for anthrax pneumonia, it's not spread person to person. So they could just ask, this could be one of their, infection control questions they might ask you about. So you don't need to do anthrax pneumonia. And the key thing with anthrax pneumonia is you get a wide mediastinum. That's the classic way to present. So they may tell you there's bioterrorism event happened, you got people coming in with pneumonia, and they show you a chest x-ray, or they just tell you everyone's got wide mediastinum with it. Be thinking anthrax. That's the one of the bioterrorist things that would do the wide mediastinum. They still could give you the skin lesion in the kid who works on the ranch. Treatment is Cipro, pretty much, is what they would give you. I don't think they'd want you to treat it. They want you to figure out what's going on because you are the front line of defense for the United States. Okay, as a primary care physician, you need to identify these things and then notify the appropriate public health authorities, which is exactly what happened with the case of anthrax that we had. It was primary care people who figured out something weird was going on and then got things moving. So the boards know that. They're going to want you to be able to identify some of these on the test. So this is anthrax pneumonia. See how wide this mediastinum is? Okay. See how wide that is? Okay. Okay. Another bacillus, okay, is B. cereus. And this is where generally going to be a classic one on the test it's the college kids who order Chinese food, and then they let the rice sit out overnight, and then they wake up from the drunken stupor, and then they go eat some more of the rice that's been left out for like 8 hours, okay? And they get sick. So if usually with the fried rice left at room temperature is this emetic type. So what's happened is down in the fried rice, the B. cereus has formed the toxin already. So the B. cereus forms a toxin. You eat the toxin, and you immediately vomit, okay, very quickly, within 1 to 6 hours of eating the bad rice, okay? So this is the emetic form. Or it's possible the B. cereus is in there, hasn't formed the toxin, so you swallow the B. cereus, and it gets into your body, and then 8 to 16 hours later, by then the toxin starts forming, but it's already in your colon or small intestine, and you get diarrhea. So there's two different ways you can present. If it's early from the toxin, you'll throw up. If it's later formed inside you, it'll be the diarrhea. Okay, treatment is just supportive. The other weird thing that they'll sometimes put is if some kid has got like an arrow in the eye or some foreign body stuck in the eye, a pencil or something, B. cereus is the thing to look out for. So that's pretty easy to remember. It's pretty serious to have something stuck in your eyeball. So just remember Bacillus cereus for that. And it shows up occasionally. These two, or it can be an IV catheter infection, probably not show up on your PEDS boards, general PEDS boards. The arrow thing might. Just know that you're going to use IV vancomycin for this, okay? All right. All these Clostridiums. Okay, so let's hit these here. So C. diff, antibiotic-associated colitis, we'll talk about more later, so we'll kind of skip that one for now. Now, botulism, you really just be familiar with this. It shows up a lot as a distractor on the test. What they try to get you to do is get this confused with Guillain-Barré. Okay, so they'll give you some history of diarrhea, and then now the patient, starts having distal, muscle weakness, and then and they have no reflexes, and you just need to remember, okay, that's Guillain-Barré, okay, distally. Now, with botulism, what happens is usually in the question, there's some sweet grandmother who has given the baby honey, or they've eaten. I think there was a couple of cases with hot dogs again, or it was hot dog chili. So it's hot dog chili in the United States. I think it was the last good botulism outbreak we had. So someone's gotten hot dog chili, and now the baby just lays there. He doesn't move, okay? And so that's kind of classic for botulism, all right? So it blocks the presynaptic acetylcholine release. So honey to babies was the classic one, still is probably on the test. Clostridium perfringens, this is just a food poisoning thing, kind of like Staph aureus food poisoning, where you can get a diarrheal-like illness, usually from contaminated meat. And then this is more for the adult. People see septicum, you get worried about the GI malignancy associated with that. And then gas gangrene, if they have that, it commonly is due to one of these Clostridium. And the main toxin for all these is an alpha toxin. Now, the big one we need to talk about of this whole group is this case. So let's start with this. So here's Marla. She's a 12-year-old child. She steps on a dirty nail with cow feces on it. Her dog licks the foot after the injury. She's had 4 tetanus immunizations in the past, and her last immunization was 6 years ago. Which of the following, if any, does Marla require today? Does she need a Tdap only, a DTaP only, a Tdap and tetanus immune globulin, a DTaP and tetanus immune globulin, or no further immunization at this time? So what do y'all think? Okay, we're kind of all over. All right. So let's spend some time on this one. All right, so let me just leave this up here. So how old is Marla? 12. All right, what's our cutoff for using a big D? 6. So is she older than 6? Yes. So people who pick B and D, you're wrong because of that for sure. Okay, she doesn't need the big D. All right, so that narrows it down to the A, C, and E people. All right, so next thing is this a dirty wound? Okay, so the question always comes up, well, how do I tell if it's dirty or not? They'll make it about this. I mean, she stepped in cow poop. The dog, some of you thought, well, the dog licked it and that made it clean because you're dog lovers, okay? Anyway, and then some of you are like, well, that made it really dirty. Okay, so it's a dirty wound, right? Okay, now the deal with dirty wounds is how many shots do you have to have before you have enough protection where you never have to get immune globulin? Okay, if you have 0, 1, or 2 immunizations in your life, and you get a dirty wound, you need to get immune globulin. If you've had at least 3 shots sometime in your life for tetanus, you don't need to ever worry about getting immune globulin. Okay, so how many shots has Marla had? 4. So she's had at least 3. So any answer with immune globulin in it is not right. Okay, so C and D are thrown out here. Okay, so C and D are thrown out because they have immune globulin. We know she doesn't need immune globulin because she's had at least 4 shots. She's had at least 3 shots now. So that leaves A and E people. So this is dirty wound. What's the cutoff for needing a booster for a dirty wound? It's 5 years. So how many years has it been since hers? 6. All right, so she needs a shot. So the only thing that's left here is A, the Tdap. Okay? Now, that's exactly what she needs. She needs A, the Tdap. Okay? It's been more than 5 years since her last tetanus. She's had enough tetanus immunizations to protect her. So all she needs is just a booster dose, and she'll be fine. Okay, so A is the right answer here. Okay, here's all that in words for you from what we just said verbally, so you can get it. So just read through this again, and this tells you when to do it or not. Okay, so men, clean wounds is 10 years. Okay, dirty wounds is 5. And remember, the only time you're going to give immune globulin is if you've had less than 3 immunizations. Now, this number 2 here is important because if they give you somebody who came from a country where you don't have records of what they got, or they're an immigrant, illegal immigrant here, and you don't know what's going on, then you're going to have to assume they never got tetanus. So if there's no immunization history at all, then you're going to go ahead. In this case, you would give the immune globulin and the vaccine. Okay, so no immunization history, especially from someplace internationally where they may not have access to tetanus immunization. For sure, give them the immune globulin and give the vaccine. The other thing is that they may ask you about how do you give an immune globulin and a vaccine. So remember with HBIG, so HBIG and vaccine, this is the same thing with tetanus, immune globulin and vaccine. You want to make sure you can give them at the same time. That's not a problem. Give them right then at the same time, but they need to be 2 different sites. Okay? So if you put the immune globulin in the right deltoid, and then you put the vaccine in the right deltoid, what's going to happen? The immune globulin is just going to bind up the vaccine. There's not going to be a response from the body to the vaccine. So you need to have them in 2 different sites. Okay? It can be at the same time, but 2 different sites. Right, so this is what we're trying to avoid is this. This is tetanus. And another poor child. Okay. All right, gram-negative cocci. All right, let's do a case. This is Wesley. He's a 25-year-old college freshman. He's 25 and going to college because he's from the Jersey Shore. Finally got out of high school. So I used to have, like, Mississippi. Those of us from the South are so happy for this show, okay? People making fun of the South about how backwards we are, blah, blah, blah. You've got the Jersey Shore now. So some of you are like, well, I don't know what he's talking about. There's Atlantic City? What's he talking? No. So this is Snooki, maybe. I don't know. Or no, not Snooki yet. Okay, this is Wesley. All right, so Wesley's 25. He comes in. He's got Neisseria meningitis. He lives with his girlfriend who's pregnant. Ooh, maybe it is Snooki. And she works part-time in daycare. No, she's not doing that. All right, you see him in the emergency department and examined him for 30 minutes in a closed room. A nurse checked him in and held his hand while she took his vitals. It was very sweet. Who should receive rifampin prophylaxis? A, nobody. B, only the girlfriend and you as the physician, the girlfriend, you and the nurse, the girlfriend, you, the nurse, and the daycare. So who should get prophylaxed? What do y'all think? Okay. So first thing here, the answer is A. What? So 89% of you missed this. All right, so let's go through. What is the girlfriend's problem? Okay, why does they make her? She's evil, right? And this is simple. She needs prophylaxis. Yes, she does need prophylaxis, but she's pregnant. And what do we prophylax pregnant women with? Ceftriaxone. We don't use rifampin for prophylaxis here. Okay? So this is how the PEDS boards get you. Okay? Is you have to look for clues like the pregnant woman. That's evil. That's your first thing. And again, I apologize. You're in the same spot as, of course, because no one moves here. So I apologize to you now. You're not evil. We love pregnant women. Love my wife. I don't want any of my kids to be pregnant yet, but that's okay. So she's pregnant. So they made her pregnant for a reason because they were trying to get you to do some drug to her that she shouldn't get. So be very, very careful, especially on the PEDS boards. If they're giving you a pregnant woman and you're having to treat her with something, you're just like, I'm not. not doing this. Now, some of you are like, well, he's 25, but you're working in the college. You're the college, physician there or whatever for whatever reason. So you may have to see some old person like 25, All right. So the girlfriend. Now, some of you are worried about you because the rest of you, all these other answers, C, D, and E, right, is you, right? Okay. And you're like, well, I'm not pregnant. Well, you are, but none of the rest of us, or some are, and they're just too embarrassed now to say they are. But the point here is that, okay, how long was he was in the room, or she? All right, 30 minutes in a closed room, though. Oh, my gosh. The room is closed. There's no ventilation. You're, like, locked next to him, Okay? You did a spinal tap on him, Oh, my gosh, you touched his back. All right, I know what happens in the real world, right? You're on the 8th floor. You hear that there's a case of meningococcus down in the ER, and you run and go get a Cipro, pop it, and then go, well, I might have been by the ER earlier when he was there, right? All right. So the boards know that, okay? And especially ID people know that. And so the only time that you as a physician or a healthcare worker should be getting prophylaxis is if you live with the patient, which hopefully you're not, or you gave them mouth-to-mouth, which we don't do anymore, or you intubated the patient, okay? So if you intubated the patient, that's who you look out for. So they may give you someone who's intubated the patient, and they got right in their face, oral secretions. That person should get prophylaxis, okay? Or if you gave mouth-to-mouth. Otherwise, though, you don't get prophylaxis, okay? You don't get prophylaxis. Remember, the guideline also says you have to ride on an airplane with them for 8 hours, sitting next to them for 8 hours before they'll let you get prophylaxis. Okay, so I mean, sitting in the room with them for 30 minutes isn't going to cause a problem. Now, some of you are worried about the poor nurse. She held his hand, and that's okay. Again, she didn't have intimate oral contact, hopefully, with the patient. Okay. And then the last group, you are worried about the daycare, all right, which is perfectly, I'd be worried about them too, okay, because Snooki's working there, all right? But the deal is, who has got meningococcal meningitis? Who has it? Wesley does, right? The guy. He doesn't work in the daycare. Now, could the girlfriend be colonized? Sure. That's why we need to prophylax her. But she does not have disease. Okay, someone has to have disease and work in the daycare for you to prophylax the daycare. If she was the one here with meningococcal disease, you'd definitely be prophylaxing the daycare. Okay, but she doesn't have disease. She just lives with the guy who's got the meningococcus. She may be colonized, but there's no evidence that she's spread it or anything like that. So she needs prophylaxis, yes, but she needs it with ceftriaxone. So nobody in this question should receive rifampin prophylaxis. Okay? All right. So, meningococcus, normal inhabitant of the throat. So what happens too sometimes? You send a throat culture for strep. The patient had a sore throat. You send it for strep. And the lab calls, or you see the lab report, and it says it's meningococcus. And you're like freaking out, right? Okay, it's a normal inhabitant. It's probably good to have meningococcus. It doesn't do anything in your throat. It protects you maybe from the bad meningococcus. The deal is you don't do anything about it. So if you find it incidentally, you don't need to treat them. You don't give them rifampin. You don't give them Cipro. You just ignore it. Okay, without disease, someone with disease, you don't do anything about it. The big group you want to worry about are the people with complement deficiencies. And so what you want to do is commonly they'll ask you about, so someone has meningococcus, which isn't a very common disease. So if they have it, most people will go ahead and screen. Okay, do a screening test. And the screening test you look for on the test is a CH50. Is generally what they give you, or they may give you a CH100. Okay, and all that is telling you is the complement cascade working properly? If it's not, if it's abnormal, the CH50 is abnormal, then you likely have some deficiency of a complement, usually one of the terminal complements from C6 down to C9. Okay, so the screen is just do a CH50. It's a cheap, easy little thing to do. Y'all know how meningococcus presents: fever, hypotension, diffuse, purpuric lesions, petechiae, DIC. Treatment's penicillin G. They may give you ceftriaxone. That's fine. Okay, ceftriaxone is fine. There are some cases of resistance in the States with meningococcus depend, so they could just give you ceftriaxone, and that's okay. They won't make you choose between the two. They'll give you one or the other as a choice. And then prophylaxis, all household contacts, the daycare, if they work in the daycare, or if there's a kid in the daycare who has it, you're going to prophylax at daycare. Don't forget significant others, healthcare workers with intimate oral contact, so intubation, mouth to mouth, and then the drugs, rifampin, Cipro, and ceftriaxone for the pregnant woman. Okay? All right. Gonococcal ophthalmia. Remember, this is where the newborn passes through the infected birth canal, the mom, and this is prevented with eye ointments. Okay, and this is important because chlamydia is not prevented with eye ointments. Okay, and they like to ask that. So we're doing this for GC. We're not doing this for chlamydia. This prevents GC eye infection, not chlamydia. So what happens is 2 to 7 days post-delivery, the baby will show up with this bloody green. It's like the most nastiest eye discharge that you'll ever see. And the first thing you want to do is gram stain the discharge, okay, and start a septic workup. So you gram stain it, you'll see gram-negative diplococci. And then generally, if they just have eye disease, your whole workup is negative, you can just give them the one little shot of ceftriaxone. That's fine. Just give them a shot of ceftriaxone. Now, clues to help you figure out is this GC or not. If it's in the first day, it's like the first day or the first few hours after delivery, it's not GC. Okay, it takes at least 2 days for the GC to be a problem. So it's probably more of a chemical reaction than what you put the eye in, put the stuff in the eye to prevent GC. And then 7 to 14 days, this is usually chlamydia. Usually. Not guaranteed, but usually chlamydia. Okay, so here's a gram stain, and here's these gram-negative diplococci right. There's 2 right there in pairs. Okay, intracellular. Okay, Moraxella is the 3rd most common cause of otitis media and sinusitis. It makes a beta-lactamase, so you need to remember that but for some reason amoxicillin usually works just fine. But if so it seems like it shouldn't, but probably because you get such high doses of the amoxicillin, and Moraxella is kind of wimpy, and it works okay. All right, I'm going to spend some time on these gram-negative rods here. So Pseudomonas, okay. This is about 5 questions possible on your test. Okay, so the first one, the classic one is the kid is running and has tennis shoes on, and the nail puncture wound goes through the tennis shoe, and now they have a cellulitis or an osteo. You need to know the most common organism to be worried about on the test is Pseudomonas. Okay, Pseudomonas. If they give you an IV drug using adolescent, you worry about Pseudomonas as a cause of endocarditis or osteomyelitis. If they give you a kid with poorly controlled diabetes, particularly now, if they give you, a type 2 kid, so, there's this obese adolescent kid who's got really badly controlled diabetes, and he comes in with this chronic draining ear, that's due to Pseudomonas. Okay, so they may show you a draining ear in a diabetic, it's Pseudomonas. Ecthyma gangrenosum, I'll show you a picture of this in a second. This is going to be your kid who's got ALL or some other cancer, who's got bad, severe neutropenia, and now they show up and they've got Pseudomonas bacteremia, and it'll present commonly with this round indurated black lesion. Okay, so they'll get this indurated black lesion, classic for Pseudomonas, means they have Pseudomonas bacteremia. And then hot tub rash. You can see this due to Pseudomonas. Usually it'll be in the areas where the clothing is sometimes or may not be, and it's self-limited. So when you get home and you have this rash, tell your significant other it's the hot tub rash, and then go get checked for whatever else. Okay. Okay. So the hot tub thing, maybe not so much, although I think it has showed up supposedly. But the big ones are the diabetic and the nail puncture wound through the tennis shoe and the ecthyma gangrenosum, which is here. Okay, so this is a heel, and this is the black. It's blurry, I know. It's the best I could do. So if you want, when you get home or whatever, you can Google this lesion. You can see it. You just look for images. Okay. All right, Burkholderia cepacia and Burkholderia pseudomallii. These used to be Pseudomonas cepacia, and they've changed the name just to make things more interesting. This is what you see in cystic patients, okay? If you see this in a cystic patient, know that's bad. So if you see Burke something in a cystic patient, that's bad, okay? So just remember that. This Burkholderia cepacia, that's bad. It's hard to treat. Usually it's not responsive anymore to the tobramycin that we commonly use in these kids. Meropenem, I don't think they'll ask you about therapy with this, but they may just say, now they've got this Burkholderia in there, what do you think? And you say that's a bad prognostic sign. This patient probably is not going to do very well. Okay, so this little guy here, or girl, can't tell, is what? An iguana. So if you see an iguana mentioned on the test, what is your answer? Is it going to be Shigella, Salmonella typhi, Salmonella non-typhi, E. coli 157A7, or iguana dung soup? So what do y'all think? Okay, so good. Most of you got it, but 27% used the old one that used to be on the test. This is what is seen in Asia. Salmonella typhi, this is typhoid fever, okay, which we don't see in the States. It's usually like Salmonella reptilicus or something like that, some crazy name. Just don't put typhi, okay? Look for things. Some Salmonella is not typhi. And this is classic iguana. It used to be turtles on the test. Turtles came back. Little chicks sometimes come in on the test. Chicken that's cooked in the kitchen table or whatever, not cooked on the kitchen table, but prepared on the kitchen table and then not cleaned real well, sometimes shows up. But the iguana has been the big one, okay? So typhoid fever, which used to be on the test a lot, which isn't seen very much anymore because here in the States we just don't see this anymore. And what happens is you can still occasionally see it in people who traveled overseas and then come back, but it's generally from contaminated food, milk, and water, particularly Asia, parts of Asia. The rose spots is the classic thing that they'll talk about. 1 week into the fever, they'll get these rose spots on the trunk. Treatment, I wouldn't worry about treatment. I don't think they'll ask you about that. But remember, the typhoid vaccine is recommended for travelers, so that's the main thing you have to remember. The one you have to think about, though, on the test is this diarrhea. So someone comes in with diarrhea, and you're going through the history, and they say they've got turtles, or they have pet iguana, or they have baby chicks. Just go for it. That's what they're trying to get you to do, okay? So family get-together with grandma's homemade stuffing. That's another one where, again, eggs have salmonella commonly if they're not cooked. So you know that whole business about you don't eat cookie dough raw, that's why, okay, if you got eggs in it because of the salmonella. All right. So anyway, just so you know, we do have a friend here at Med Study. We actually have 2 friends now, but this is my pet iguana. Moving from Colorado, the air kind of shrinks him down, so all the air gets lost. So this is the old Sammy. It's a Sammy Salmonella. And now, though, we have the new improved Puppet Sammy iguana. So, hi, guys. How are you? Okay. All right, that's my puppet show. Okay. So we'll do that. Oh, it didn't work right. Oh, well, usually they land on top of each other and I have to separate them. So, okay, Shigella. So moving on. So the other thing about Salmonella diarrhea, in general, we don't treat that. Okay, that may be something they might ask you about. So Salmonella diarrhea, generally we're not going to treat. Now, the Salmonella typhi we will, but the Salmonella diarrhea from, the iguana, our iguana friends, we're not going to treat. Because generally what will happen is if you treat, you're going to prolong the shedding. Now, if they're immunocompromised or it's a newborn or a small, really tiny, small infant or someone who's ill, you're definitely going to treat, okay? A sickle cell patient I would probably treat. I'd be worried about them. All right, so here's a iguana crossing the road sign. Okay. All right, Shigella. This is the daycare disease, okay? Look for it in daycare. It's going to be young children, 1 to 4. Summertime, can occur in contaminated pools or lakes. This is spread very easily from person to person. So that's why a daycare is a cesspool for Shigella, because it only takes 10 to 100 organisms. It's like 10 organisms can cause disease, so it's very easy to spread from person to person. Salmonella is thousands to millions of organisms to spread. Okay, so it's hard for salmonella to spread. One of the other reasons why we don't treat salmonella. For sure, we treat Shigella. Okay. Now, classically on the test, look out for these kind of words on the test. They may talk about a kid who's had diarrhea and now they have rectal prolapse, or they've done a CBC and they've got like 30% bands on their CBC, or the kid has a seizure with their diarrhea. Okay, so a seizure, rectal prolapse, white count with the bandemia. Think about Shigella. Okay, think about Shigella. Always treat this. Generally, we're going to use our third-generation cephalosporin. You can use PO azithromycin. It works too for this, so the kid's not that sick. And the thing to remember, I think, important is this is resistant to ampicillin. So we're not going to use ampicillin in these kids. All right, E. coli. So the enterotoxigenic E. coli, this is the traveler's diarrhea. So you go to Mexico or you go to some other country and you eat a raw vegetable that's contaminated. You get this watery diarrhea. Usually it's self-limited, but this is the one where you can just give them Bactrim. Pepto-Bismol works, et cetera, usually to kind of slow things down. But Bactrim will be just fine. The enterohemorrhagic or the Shiga toxin-producing E. coli, the 0157H7, this is what causes the hemolytic uremic syndrome. Okay? Be careful about it. Undercooked beef, apple juice has been a big one that's done it. They've had water park outbreaks in the States. The key thing here is you don't want to give antibiotics. So this is a diarrheal illness you don't want to give antibiotics to because it increases the risk they'll have hemolytic uremic syndrome. All right, Legionella, pretty rare in kids. I've seen adolescents with it, so I guess I could ask you about this with adolescents. But in general, it's a pneumonia with a diarrhea and CNS symptoms. So if they give you a pneumonia with diarrhea with CNS symptoms, be thinking about Legionella. Azithromycin is the drug of choice now. We used to use high-dose erythromycin like we'd use a gram every 4 to 6 hours. And what we forgot about erythromycin is it has hearing loss. So high dose have hearing loss with erythromycin. Okay, Klebsiella, it's a rare cause of disease in children. The big thing about Klebsiella is it's resistant to ampicillin. All the Klebsiella are pretty much resistant to ampicillin. All right, our friend cat scratch disease again. Classic symptoms in kids and young adolescents. They get this regional adenopathy. Remember, you don't aspirate it. It can present in kids as an FUO. So they talk about a kid with a fever of unknown origin that's been going on for a while, and there's a cat in the house. Add that to your list. Bartonella is a possibility. They can develop this encephalopathy with seizures. And to diagnose it, you just do cat scratch titers. Most of the time, you can figure out what's going on based on the history, right? They'll tell you about a cat scratch, and now they have this big lymph node in their axilla. And you pretty much just leave it alone. Or you can use azithromycin. There's data, a few studies showing azithromycin will help that resolve a little bit quicker. So here's a classic, the lymph node. Key is just kind of leave it alone. You don't want to send a surgeon in after that. And this is the cat bite or cat scratch. Okay. A neonate with fever grows Citrobacter in the blood. You order a spinal tap, and what other test? Do you want to order abdominal ultrasound, a CT of the head? Nothing but the spinal tap is necessary, serology for fungal infection, or serum ceruloplasmin. So what do y'all think? Okay, good. If you see Citrobacter on the test, it's just you've got to be worried about a brain abscess. Okay, Citrobacter means brain abscess. So if you see that, that's what you need to associate in your head. Okay, so a neonate with Citrobacter, just know you need to do some tests for brain abscess, either MRI or CT, whatever they give you, just pick that and you'll be right. All right, H flu. So how many of you in here have never seen a case of H flu meningitis? Raise your hands really high. Okay, wow. And that shows you how good vaccines work. Okay. How many of you my age saw, that was all we saw, or saw tons of H flu meningitis? Yeah. So anyway, this is a disease that they still are going to probably ask about on the test just because there's all these cool things associated with it, even though you'll never see a case. Okay? But the thing is, there's still kids who aren't immunized. So those of you that are younger who have seen it probably have seen it because someone didn't get immunized or they just failed to respond to the vaccine for whatever reason. So this used to be the most common cause of meningitis and bacteremia. Now, as you know, we rarely see this. Today, the most common things we see with H flu are from the non-typable strains, so the non-B strains. Still causes conjunctivitis, still causes otitis media, sinusitis, bronchitis. And there is this interesting few cases coming up every once in a while with this newborn meningitis in the first day of life. Just a strange thing that it'll show up. I don't think the boards will ask about it. It's pretty rare, but it made a blip for a while, and we were worried about it. But just be aware, I guess, that H flu, the non-typable strain, may cause a newborn meningitis in the first day of life. All right, meningitis, the problem with this bacteria was we had a lot of complications when these kids did get meningitis. So they commonly had subdural empyema. They commonly had infarcts. They commonly had abscesses form. They commonly need to have shunts. It was just a bad, bad disease. The most common sequelae, pretty much of any bacterial meningitis, so if they ask you about pneumococcus or H flu or meninge, just know it's hearing loss, okay? And this is the first group of kids where we figured out, okay, we need to use dexamethasone, or dexamethasone can be helpful to prevent some of the neurologic disease, particularly hearing loss. Okay, so dexamethasone we give. So if someone they give you a case of H flu meningitis for whatever reason, know before they get antibiotics, they should get dexamethasone therapy. All right, this is a case of buccal cellulitis, and they love to have this on the test just because they say buccal. All right, so you see the cellulitis on the outside here, and if you put your finger inside this kid's mouth, you can feel the induration all the way through. Okay, this is full thickness disease. So this is buccal cellulitis. Okay, this is buccal cellulitis. If they show you a kid with a cheek who's not been immunized for H flu, be very, this is going to be H flu. They're going to be toxic appearing, high fever, and you know they're bacteremic. You know they've got bacteria in their blood if you see this. Okay, epiglottitis generally is going to occur between kids ages 2 to 7. Again, H flu is the most common cause of this. Now other things are doing it, but we still worry about it. I'll show you a picture of the cherry red epiglottis. Generally, there's all this controversy about, you know, should you do the tongue depressor thing or not. In general, it depends on which textbook of pediatrics you read. So some say it's okay if the child's cooperative. Others are just adamant about not doing it. With that being the case, in general, their answer is probably just don't do it, okay? Because whoever's writing the question is probably trying to get you to do something that you shouldn't be doing. And in general, the key thing is you want to make sure that you can maintain an adequate airway. So as soon as you diagnose it, you want to keep the kid calm. You want to get them to an OR or someplace where they can go in and protect the airway. So this is the cherry red epiglottis, okay? It's all swollen. The problem is if you upset the kid, this all closes down on itself, and the kid can't breathe. All right, some other things with H flu, occult bacteremia. Okay, if they tell you a kid is growing, the kid looks fine, they have fever, and they said, oh, it's just an occult bacteremia with H flu, you need to jump on it. Okay, it's not the same as pneumococcus. These kids have a 30-50% chance of having meningitis or developing a deep focal infection. You always treat H flu, even if it occurs just by itself. Usually we're going to use a third-generation cephalosporin. I wouldn't worry too much about the duration of therapy here. I don't think they're going to ask you about that because this is so rare. They just want you to identify it if it does show up. And know, particularly this occult bacteremia thing, so you don't get it confused with pneumococcus. Okay, this one we definitely would have to treat. And then the other thing is, that's weird about H. flu, and it's very complicated. I mean, I have to read the Red Book. You know, every time it comes up, you got to go back and read the Red Book because it's so complicated. The thing I'd probably remember is that you do need prophylaxis for some kids. And so if I didn't want to take the time to memorize everything they had in there, I'd probably just give it. So it says if they're in completely immunized households and there's daycare contacts and the daycare requires 2 cases, then you're going to give prophylaxis. So 2 cases in the daycare is required for you to get prophylaxis because they figure most kids are immunized, and so it shouldn't be a problem. But if there's 2 cases going on, then they want you to immunize. Obviously, if it's the daycare of kids who haven't been immunized, you're going to go ahead and give them prophylaxis. The other weird thing is with this one is the index case of the kid who had the H. flu. Okay, if they did, for some reason, they didn't get ceftriaxone or cefotaxime, you have to give them rifampin. Okay, so like if they were allergic or whatever. All right, plague. So sometimes I'll ask you something really stupid, like how is this transmitted? And you know it's a flea. Okay, this is a flea. A flea transmits this, not a tick. Okay, so plague is with fleas. There's 2 types. The bubonic form is where you get the big lymph node. Those of you from the desert southwest area see cases of this. Okay, so they're likely to give you geography, some from New Mexico or Arizona or parts of California. The pneumonic form is very contagious by coughing, and the way you'll see this on the test is, again, this is our bioterrorism agent here. So plague pneumonia. It's a very good bioterrorism agent because it's easily spread from person to person. Okay, it's a hemorrhagic pneumonia. If you've got a big bubo, you can aspirate the lymph node to make the diagnosis. So this is a CDC picture just showing you the big bubo. You could aspirate that and look for the organism. For bioterrorism, pneumonia is the biggest problem. What they'll give you, if they're going to give you a question about a bioterrorist event, is like there had been this football game or something, and now you got all these young people, or it's military recruits, or college kids in a dorm or something that someone was trying to terrorize or do something to. So young people with a hemorrhagic pneumonia, high fever, and you need to know when you admit them to the hospital, they need to be in respiratory isolation. I think that's what they might ask you about. Again, an infection control question they could throw in. All right, pseudoappendicitis syndrome is due to Yersinia enterocolitica. It's a classic one they like to ask about. If they give you some history of a caregiver who's making chitlins or chitterlings in the South in general is where you'll see that. So pig intestine, this is where you'll get it from. Okay, so they'll usually commonly be grandmas making it, and then the kid gets sick and has this diarrheal disease, and you need to be worried about it. Or they talk about some kid who is old enough that it looks like that they have appendicitis, and it turns out it's due to this bacteria. The other group you worry about is sickle cell patients. They can get bacteremia with this. For some reason, they can get bacteremia with this if they're in iron overload states. So people with sickle cell, who've got lots of transfusion, they've got iron overload, they're at higher risk for developing bacteremia with this bacteria. Again, they like to put this on because of the funny names. Yersinia pseudotuberculosis causes a pseudoappendicitis. All right, tularemia, briefly, this is a tick infection usually, or coming into contact with an infected animal, particularly a rabbit. Okay, particularly a rabbit. They get this ulceral glandular disease. This is one where you just want to check serology. So they'll have this big lymph node, but you don't want to aspirate this. Okay, because this one is very, very dangerous for the lab. So they'll be very angry if you say, hey, could you culture tularemia for me? They won't like that. So here's where we're going to use streptomycin on the test maybe. So streptomycin or gentamicin if they're ill, and then tetracyclines if they're not that ill. So here's where tularemia is. So the bullseye, you know, Arkansas, Missouri, Oklahoma. Okay, those are the 3 big states that show up on the test. Those of you around the country, though, look, there's a lot of states that have cases of tularemia, over the last decade. So kind of interesting. But the big ones, if the test is going to ask you about it, that they'll put it there. So Hawaii, no tularemia there. Alaska had some cases though, so that's kind of interesting. But anyway, this is where Arkansas, Missouri, Oklahoma. All right, so here's a kid that we had seen when I was at Arkansas, and as you can see, he's got this lymph node here. He's also not very happy getting his picture taken. And this is the node enlarged. So they have a tick bite, and generally upstream or downstream from the node, that'll develop a lymph node. Well, they get the ulceral glandular form. This guy was a skinned rabbits, and what happens is you can get a conjunctivitis with this, as well as a big node. Can't see his node real well. It's over here, and here's his conjunctivitis. Does anybody tell me where he was a patient at? VA, good. So this is VA pajamas, standard. All right, and this is the conjunctivitis that you get with it. And then you can in kids particularly, you can sometimes just get a pneumonia with tularemia. So you can outbreaks with that. So the classic case was this kid in the Northeast who was mowing the grass, ran over a rabbit. The rabbit aerosolized in the air and got pneumonia. So the kid got pneumonia. So, all right, so here's your case. All they have on the question is Arkansas. That's all they say. So which of these is true? Arkansas and a lymph node is tularemia. Arkansas and pneumonia in an adolescent hunter with skin lesions is blastomycosis. Arkansas, no tick bite, and a cat scratch with lymph node is Bartonella hynsulae. Arkansas and X-presence from there, maybe some scandals. And then E, all of the above. Okay. It's all right. I'll pick on the Republicans in a few minutes, so it's okay. I'm an equal opportunity picker on her. So. Okay. So some people, the A people just don't believe in D, so that's okay. I mean, you're okay. I'm okay with that. So actually it is, well, A, B, and C definitely are true. Okay. A is definitely true. B, Kim will talk about blasto and pulmonary, but you'll hear about blasto and it's a pneumonia with skin lesions kind of deal. Arkansas is a good state for it. Missouri, Chicago area actually has cases of blasto too. And then C is true. Now, Arkansas really has nothing to do with this, but if you have a cat in the question and there's a scratch, okay, what do you think it's going to be? Botulism, right? No. So, and then D, I'll leave to y'all to figure out. Okay, rickettsial-like organisms. All right. So let's talk about Rocky Mountain here. Okay, so Rocky Mountain spotted fever, which is the stupidest name because this does not occur in the Rocky Mountains. Okay? So don't get confused. It was actually discovered there, but it's not really, we see cases rarely in Colorado. But anyway, I'll show you a picture of who you need to be worried about on the test with this. So this is a tick disease again. It's a rash on the distal palms and soles. And classically on the test, they'll give you a low sodium. Okay, so it'll be summertime. They may not talk about the tick because that kind of helps give it away, but they'll mention geography like North Carolina or South Carolina or Georgia. And then they'll say they have this rash on distal palms and soles. They'll be pretty sick, and they'll say the sodium is low. Okay, so sodium will be like 128, 131. And then they'll want you to know just tell them what it is. Usually, so you'll just have to say Rocky Mountain, or they'll say, what do you want to treat this with? And you'll say doxycycline. Or they could ask how you want to diagnose this, and you want to get specific Rocky Mountain serology. Okay. They still may have this stupid wheel Felix test on there. Don't get that, or don't get some panel, some tick panel or something. So once you figure out where the geography is, hone in on the exact disease you think it is. So Rocky Mountain would be the one, depending on what they talk about. I wouldn't worry about these bolted ones down there. There was a couple of outbreaks of this in New York. In New England Journal had a couple of series about it, but I don't think I'd worry about too much for the PEDS boards. So this is where Rocky Mountain is in the United States. Most cases, though, on the boards are going to be over here. Okay, so this is North Carolina, South Carolina, Georgia area. Okay, classically what they'll give you, maybe Virginia. So mid-Atlantic states to the southern coast down here. All right. Notice Florida and Louisiana. We have on our borders we spray and we don't let the organism is. Actually, we have no health department at that time, so we couldn't report anything. So. All of our funding was gone for that month. So anyway, so there are cases down here, obviously. And look, cases here, and you know who carries the organism here? The squirrels. Okay, so look out for the squirrel fleas. Okay, when you're outside here. All right. So this is, for those of you that live in Rocky Mountain area, the problem is it usually is a summertime disease, and what else or spring to summer, what else is occurring at the same time? Meningococcus. And it's really hard, and they're very different treatment. I mean, doxycycline is for Rocky Mountain spotted fever, and then meningococcus, you're going to be using like ceftriaxone or a penicillin, which isn't going to cover Rocky Mountain. So commonly what happens is particularly if there's an outbreak going on in the community, you're going to be using both drugs at the same time. So, but if they give me geography and they, talk about petechial rash and low sodium, I'm going to pick Rocky Mountain spotted fever. That's what I go with on the test. Okay, so here's the petechial rash. All right, Ehrlichia, Anaplasma. Ehrlichia, it depends on where you are in the country. They both cause the same disease presentation, okay? So Ehrlichia is mainly going to be Arkansas, Missouri. Again, Arkansas, Missouri, Oklahoma is where you'll see Ehrlichia. It causes a flu-like illness, and the key thing about this tick disease is they'll have a low white count, they'll have anemia, and they'll have low platelets. So they get a pancytopenia. So all three cell lines are diminished. You diagnose it with serology. Occasionally you can see it on a peripheral smear. Just see the morula on a smear. And the treatment's doxycycline. Anaplasma, pretty much the same disease, but it affects the neutrophils instead of the macrophages. And then it's going to be the Northeast, upper Midwest, like Wisconsin, and then California. Okay? So same places we were talking about Lyme disease, you see anaplasma. Same disease, pancytopenia, same treatment, doxycycline. Okay, some mycobacterial stuff, and then we'll take a break. We'll get through this. So, scrofula. Okay, so you've all seen the 2-year-old kid with the big lymph node. There's no cat in the question or anything, and they've been on antibiotics, and it just doesn't do anything. And then it starts draining. And then what you need to know is, the answer is you need to take the node out because it's probably an atypical mycobacterium. Okay, usually due to MAI, Mycobacterium avium intracellularly, or one of the complexes. And the best treatment is excise the node still. There's been some people trying to use clarithromycin to see, but the answer for the board still, I think, is excise the node. Okay, just take the node out. Leprosy, I don't think they'll give you on the, they're not going to waste a question on PEDS boards now about leprosy. It's seen in Texas area, armadillos carry it, but I just don't see them asking about that on the PEDS test. They might particularly ask you about Mycobacterium marinum. Either it's going to be a kid who has a lot of fish, so has fish tanks, like 2 or 3 fish tanks in his room, or it's a kid who works part-time after school at the fish store or whatever, or works with with cleaning fish or something like that, or it's a lifeguard. So you have to have some exposure to water. So Lifeguard Kid is the other one where you'll see this disease. Classically, what happens with this is they'll have been on Keflex, Augmentin, all these regular antibiotics. You think, oh, maybe it's MRSA, so you treat them for MRSA with Bactrim, and nothing's working. And then finally, you go through the history and you see fish tank, or you see swimming pool exposure like a lifeguard. Then you think, oh, okay, it's Mycobacterium marinum, not responding to usual antibiotics. So they really just want you to diagnose it. You're not going to worry about treating it. You get these lesions, like particularly with the fish tank, they stick in the arms in and out of the fish tank. You get these lesions along the arm that just don't heal with antibiotics. Okay, TB, this is where what you need to realize is children get TB from adults. Okay, children are going to get TB. Children aren't running around spreading TB. The adults are the bad people. Okay? They're the ones spreading it to kids. Most kids who have tuberculosis don't have signs or symptoms. Now, the ones who we worry about who could are the infants and the adolescents, because the adolescent's going to act more like an adult. What you need to know is that primary TB infection, so your first exposure to TB, you get it, so like I get exposed, so tuberculosis gets inside me, all right, and what generally is going to happen is it's going to become latent tuberculosis infection. Okay, so my exposure generally is going to be my body's going to take the organism, keep it under control, and not let anything else happen. That's what happens to most people, okay? So most people do not have an active pulmonary disease with their initial infection. So the body recognizes it, tries to keep it under control. It doesn't kill all the organisms. They keep replicating, but it's kept under control until something happens down the road to cause it to come out. Okay, so that's how most people react with their primary infection. Now, pulmonary disease, so this is where you actually have pulmonary disease in your lungs occurring with the primary initial infection, is going to be seen more commonly in adolescents and in HIV-infected patients. Okay, so HIV-infected patients, particularly an HIV-infected adolescent, I'd be worried about, and this is going to cause a lower lobe disease. Okay, and these are important things to know because this is different how you differentiate this. So primary disease, you get your first infection with TB, it goes into your lungs. You're initially going to get infection. If you're going to have the full-blown disease with tuberculosis, it's going to affect your lower lobes. Now, pulmonary disease, so let's say, okay, I get infected here today. 10 years from now, I get on chemo or whatever, and my TB gets out of control. Then what's most likely going to show up, I'll get disease in my lungs, but it's going to be the upper and apical lobes. Okay? So disease years later after your initial is usually upper or apical lobe. Pleural fusions are pretty rare in kids, especially those under 6, but they can occur particularly in the adolescent child. So the adolescent probably may have a fusion to help you kind of figure out something weird's going on here. If you tap these, you'll see lymphocyte counts. The glucose is low, the protein is high. Okay, glucose is low, protein's high. The key here is that the AFB fluid is going to be smear negative. Okay, so you do a smear, they say it's AFB is negative, and you go, oh, okay, well, you expect that. So TB is not ruled out with the smear. What you generally need to do is do a pleural biopsy. And for PEDS boards, that's still what they're probably going to ask you for, is a pleural biopsy. There's some newer tests that I don't think PEDS is ready to ask you about it yet. We'll see. All right, pericardial fluid. Now, this is about 400,000 in kids. What they'll describe is you'll hear the distant heart sounds. So you'll hear a rub or distant heart sounds. And again, the fluid's negative, and you have to do a biopsy again. TB meningitis is more common in kids, and we see it more commonly in kids between 6 months to 4 years. SIDH is very common. They may give you an MRI, and they talk about posterior enhancement. So they talk about an MRI. So they got lung disease and this posterior enhancement on the MRI. Be thinking tuberculosis. That's what they're trying to tell you. I wouldn't worry about the tuberculomas because it's so rare here in the States. Okay, now TB in adolescents is like TB in adults. So TB in adolescents, you get fever, night sweats, weight loss. They're contagious. They cough. They have hemoptysis. And again, it's upper lobe. Okay, generally upper lobe is most common with a hilar lymphadenopathy. Again, because most commonly, most people don't get the primary disease. Most get the delayed disease with the lung. The adolescents more likely to have the primary with lower lobe, but even among the adolescents, when they get it, they're likely to have been exposed sometime in the past, and now it reactivates, and they get upper lobe disease. So here's just showing you an infiltrate here in the fissure between the right upper lobe and middle lobe. All right, skin testing. It's pretty easy. Just remember HIV or cell-mediated immune dysfunction, it's 5. Okay? Or if you live with somebody who has active tuberculosis, it's 5. So a kid who lives with someone who's got TB, like an adult who's got TB, and the kid comes up 5, that's a positive test. The other one they may ask you about is steroid use. So they've been on prednisone at least 50 milligrams per day for over a month. The 10 is the harder one. This is pretty much everybody who's not quote-unquote normal, but kids under 4 fall in this category. So children under 4 are 10. Now, if the kid is under 4, but they live with somebody who's got tuberculosis, it's 5 again, right? So that trumps everything. Living with someone TB brings you down to 5. So this is where we come in, healthcare workers, we're 10. The homeless are 10. Diabetics are 10. And then lower dose prednisone gives you a 10. But everybody else is 15. All right. The other thing with skin testing is you need to remember it's not reliable in children under 6 months of age. Okay, so we're not going to put a PPD. You may, but it's not. You can't rely on it. The other thing you need to know is it may take up to 10 weeks after exposure to turn positive. So generally what happens is they go in, they found an exposure, they test everybody today, and then in 10 to 12 weeks we test everybody again just to be sure. All right, this is this new test, this interferon gamma release assay, or the IGRA. Okay, quantiferon, TB Gold, Gold in the Tube, these are all the brand names for this thing. What this does is it's measuring ex vivo interferon gamma production from T lymphocytes in response to stimulation with antigens that are specific for MTB. So essentially what it's doing is it telling you has a patient been exposed to tuberculosis or not. Okay. Now it can't tell you if they have active disease or latent disease. All it tells you is they have had exposure to tuberculosis. Okay, which is what our PPD is telling us. All the PPD is telling us is we've had exposure. It doesn't tell us we have active TB, just says we've been exposed to it. It appears to be more specific than the skin testing. It's also a whole lot better because you don't have to rely on someone to come back, and you don't have to rely on someone reading it who doesn't know how to read a skin test. Okay. You can use this, it's okay now, you can use this in immune-competent kids 5 and older in place of skin testing. So this may pop into the PEDS test now. So you can use this in kids older than 5 and older. If they're positive, they're infected with tuberculosis. Okay, now it doesn't mean they have active disease, it just means you know that they have positive tuberculosis exposure and they've been infected. If they're negative, however, it doesn't rule out the infection, but neither does a negative PPD, right? So you have to base it on your clinical judgment. But it's helpful because if it's negative and you've got low suspicion, then you're pretty much going to say it's okay. This is good in kids who have received BCG and adults. For those of you that got BCG, this may be the way you want to go as far as TB skin testing. If you've been getting skin testing and you don't react, that BCG is long gone. Okay? But for kids who may have recently received BCG, it's useful because it doesn't cross-react with that. You can't use it in kids under 5, and you can't use it in anyone immunocompromised. All right, so let's just do a brief question here, and then we'll go to break. So question 1 of 2 on TB. So here's a PPD we placed on, it comes back 16 millimeters in a 12-year-old girl who has a history of TB exposure, and she's got this productive cough. What do you want to do? Do you want to start INH on her for 9 months? Do you want to do nothing? You want to check chest x-ray on her and sputum, and if both of these are negative, start her on INH. You want to check a chest x-ray, sputum, and if either of these positive, you want to start INH for 9 months, or do you want to repeat a PPD in 2 weeks to be sure this is not a false positive? So what do y'all think? Okay, good. So 48% of you got this right. So here's the deal. Is her PPD positive? Yes. Okay, she's positive for anybody. Okay, it doesn't matter. She's higher than 15, so she's got a positive PPD. All right. So the next thing is, so she's infected with tuberculosis. Okay, she's infected with tuberculosis. Now what you have to decide is, does she have latent disease, which means she only needs INH, or does she have active tuberculosis? So with active tuberculosis, where do we look? You need to look in the lung. So you need to look and see if she's got a positive chest x-ray, a normal chest x-ray, and you need to look at her sputum. She's 12. They say she's got productive cough. She's coughing up stuff. So you can go ahead and send that. That's not going to be a problem. Okay? Remember, in younger kids, we can do the gastric, right? So that's the other thing that you can do. So we would do that in her. And if those are negative, so it means the chest X-ray is normal, okay, and her sputums are negative, we're just going to say she just has a positive PPD and does not have active disease, and she just needs INH. Okay. If her chest X-ray comes up positive, abnormal, or she has positive sputum, then we're going to say she's got active tuberculosis and she needs 4-drug therapy. Okay, not just INH. Okay, so the D, if she has abnormal disease in her lung, she's got active tuberculosis disease and she needs 4-drug therapy. Okay. The E, you're never going to repeat a PPD. Don't do it. It's not the right answer ever. Do nothing. A lot of times on the pediatric exam is right, this time not, okay? And then you need to make sure she doesn't have, if she's really got TB in there, then you need to make sure, because you're not just use INH alone, okay? So C is the right answer here. Good. So the second question is, if you diagnose active TB disease, which is what we did, or sorry, which we did not do or in that case, but let's say we did diagnose active TB in her, how do you initially treat it? Do we give her INH rifampin unless resistance is greater than 0.5%? We give her INH, rifampin, PZA, plus or minus ethambutol or streptomycin. Do we give her INH only? Do we give INH, rifampin, ethambutol, or I don't? I just have my nurse go, and she can call me if there's any problems. Okay, what do y'all want to do? Okay, so B, and actually this question's bad because D, maybe there, oh, that's right, you got to have PZA in there, never mind. So B is the right answer here. So INH, rifampin, PZA is pretty much standard, okay, and then you may or may not add a 4th drug for kids, depending on what your health department's doing, okay. So B is the right answer here. So with these drugs, just remember INH, rifampin, PZA are hepatotoxic. Remember INH, you get the peripheral neuropathy that we had in the test question. So remember that. What about testing these people with lab? Okay, generally it's out. We don't do that anymore. So you need to follow them with, check their liver functions, all that, only if they have symptoms. Ethambutol is different in that it's not causing liver problems, but it can cause a decrease in visual acuity, particularly color perception. So they usually have to be followed to make sure that they're not losing color perception. And then streptomycin, vertigo, and ataxia are common in kids with this. So just be aware of that. Okay, gram-positive bacilli. We only have one to talk about here. All right, so actinomyces. So this is an anaerobic infection, and the Peace Boards loves this supposedly, okay? Just because there's weird things here. So sulfur granules. So this organism has sulfur granules, which all it is just clusters of organisms. I'll show you a picture of it in a second. And the common thing we see with this, there's 2 things the way it may present. One is like a dental abscess where it's drained out of the mouth through the skin. So like they have like a draining lesion coming out of their mouth or the side of their mouth or cheek. And then if they've got an IUD present and they get PID, for some reason this organism is more commonly seen with that. Okay, so a woman, young girl who has an IUD and she develops PID, be worried about actinomyces. Penicillin works, ampicillin. So this is the sulfur granule thing. Okay. All right, chlamydiophilia, which used to be chlamydia, which they changed the name for some of them, but not all. So the ones they changed are these. So this is the first one is psittaci. Okay, this is the one where people have exposure to birds, okay, poultry, parrots. And this is one of those weird pneumonias with splenomegaly. Okay, so you'll hear, we'll talk about Coxiella burnetii probably tomorrow. That's the other pneumonia, splenomegaly. Okay, but this chlamydia is a pneumonia with a big spleen. Okay, if they talk about that and there's some bird in the history, just pick it. Okay, they'll have high fevers, they'll have pneumonia, they'll have a big spleen. Chlamydia pneumoniae, this is the one that we commonly see in adolescents with community-acquired pneumonia. Remember, it's person-to-person spread. This one is not from birds. And they commonly have wheezing with this. So they'll describe wheezing with their pneumonia. And treatment is the tetracyclines, doxycycline, azithromycin, any of the things like that. All right, Chlamydia Trichomonas. So this one didn't change its name. It's still chlamydia. This is where, again, newborns, generally we worry about newborns. They're going to get it from their moms as they come through the birth canal. This is the thing. They sometimes will ask about the eye ointments, and this does not prevent transmission. Okay, the eye ointments are preventing GC. It's not preventing chlamydia. The classic way they'll present this on the test, though, is the pneumonia in the first 4 months of life. And they'll give you some words here that if you see these words, just pick it. If they say a staccato cough, okay, if they say staccato cough, that means they've got Chlamydian pneumonia, okay? So what happens is they get the pneumonia so first they get the Chlamydia conjunctivitis, or they get colonized chlamydia, and if they are, then 10 to 20% of them will develop pneumonia if they are infected. So pretty high attack rate for pneumonia. It's usually they're afebrile. That's a clue on the test. So you got a 3-month-old baby who's afebrile with the pneumonia and a staccato cough. Treatments, oral erythromycin. Remember, there was all this controversy about these kids had an increased incidence of pyloric stenosis. So you got them, you treated them with erythromycin, and somehow the erythromycin potentially increased the risk of pyloric stenosis. So they might ask you about that. You know, what's a potential increased risk? It's still controversial. Okay. So spirochetes. So lepto. All right, so let's do a case here. Here's Jethro. Jethro swims with his dogs in a pond. There are cows there too. There are pigs there too. Paris Hilton's there. Jethro likes to go swimming. He gets sick and presents 2 days into his illness. How would you diagnose his infection, a fever, headache, elevated liver enzymes, if the dog is harboring the infection? So do you want to kill the dog, culture Jethro's blood, culture Jethro's urine, biopsy the dog, or kill a cat just because? All right, so what do y'all want to do? Okay, so, oh man, 12% want to kill a cat. Only 1% want to kill the dog, but some want to biopsy the dog. So 19%, 1 out of 5 of you wants to cause harm to an animal. Okay. All right. So this is early in this infection, and actually it would never present this way, okay, because the liver stuff doesn't show up till later. All right. But early in the disease, and this is leptospirosis. Earlier in the disease with leptospirosis, you find it in the blood. Okay, so blood would be the way you'd find this early. And then later, you'll find it in the urine. Okay? Now, the key thing here is this swimming with your dog business. Okay? So dogs carry leptospirosis. Our dogs are immunized against it. Okay? Depending on where you live, most of your dogs are immunized against leptospirosis. Okay, the problem is, all it does is it prevents them from getting sick from it. Okay? But they still have the organism a lot of time, and they still excrete it in their urine. So what happens? You swim in the pond with your dog. You swim around with your eyes open, your mouth open. The dog swims around peeing in the water. The little spirochetes in the urine get out. They go into your mouth. They go into your eye. They go into mucous membranes, okay? And you get infected, and that's how people get infected. Now, Hawaii's #1 because the rats there that live by the water excrete it as well. Lepto was seen with rats. So look out on the test if they talk about someone who's cleaned out, a garage and there was a bunch of rat droppings or rat urine, things like that in there. Be very worried that they're going to get leptospirosis. Okay, and we'll talk more about this disease with the zoonosis talk tomorrow morning when we kind of hit it better. But early you do blood cultures, late is urine. Hawaii's #1. So if they have a Y on the test, this is the only reason I can think of, is that they'd have leptospirosis. Okay, this would be where you'd get it. Okay, we're not going to talk about Lyme because we did that in room. Fungal infections, we'll hit these real quick. Y'all are real familiar with some of these, some not so much. So Candida, as you know, is a common cause of thrush, the common cause of diaper dermatitis. You can diagnose this to the cows come home, right? You know how to do this. We worry about in immunocompromised patients, particularly our leukemics, because if they get systemic disease, then they can become very, very ill from it. So classic diaper dermatitis, right, from Canada. Remember the satellite lesions, right? So here's some good ones. So it's all red, and then you go way out, and there's satellite lesions. Classic for Candida diaper dermatitis. All right, for thrush, remember you can do the, if you remove, they always talk about, you remove it, and under the white membrane, you see a red base. Okay, nystatin, other things are available now. Grandma likes Genesian violet because it, stains everything and looks like they're doing something. Okay. This is Canada. Okay. All right, now who we worry about, though, who's more at risk? And so these are some just patients on the test to be worried about if they present to you and they look sick. So particularly someone with malignancy who's got an IV catheter, and it looks like the catheter might be infected, or they have a high fever, be thinking about Candida as an etiology, particularly if they tell you they already have Candida in their urine. Okay, so they already have Candida in their urine, and they're febrile neutropenic with the line, IV central line, be worried that that IV central line may be infected as well. Diabetics, we talked about with Pseudomonas with the ear. They also are more predisposed to getting candidal infections, so yeast infections in these patients are much more common. Any patient on steroids, okay, so they have asthma, they have to have a burst of steroids for a while. They're more likely to get Candida infection, and then the burns, things like that. So leukemic patients, all these things here make you at risk. So in particular, having candiduria, though. So if you have Candida in your urine, be very suspicious that they may be on the way to developing Candida in their bloodstream. So this is disseminated Candida. Okay, this is disseminated Candida. All right, invasive malassezia. Now this is a weird name, so they like this. And you need to be very familiar with this because this is a strange presentation for a disease that's not that common, but they like to talk about or have it on the test, I think, because of just the way it's just something to be thinking about. And also it doesn't respond to the usual things we use sometimes for therapy. So look out for the low birth weight kid, less than 1,000 grams, who's in the NICU. They've got an IV catheter, and in the question they say they're on lipid hyperal. Okay, they got fat. There's fats in their hyperal. Okay, whatever your nutrition you're using, their hyperal's got a lot of lipid in it, or lipids. Commonly, they can be asymptomatic, but on the tests, that doesn't help. They're not going to give you an asymptomatic kid. So they're going to give you fever, respiratory distress, big spleen and liver, high white count, low platelets. But they talk about lipid in the question. So lipid in the question should steer you towards this bug. You diagnose it with blood cultures, and this is what's kind of crazy about it. It requires this olive oil overlay on the media to help it grow. So they may talk about that or say something about olive oil in there. You're like, what the heck? Treatment, you get rid of the catheter, you stop the lipids, and you put them on Ampho-B. Okay, so any kid, any age who has a fungus in their central line or has a fungemia with a fungus in there and they have a central line, you got to pull the line. Okay, always pull the line. All right, athlete's foot, very common, particularly in adolescent males in particular. And some poor ID fellow had to do a study, and the most common place it's done is between the fourth and the fifth toes. You get itching, you know the whole story here. Okay. Topical therapy is curative, and the deal is that most time they've tried the over-the-counter stuff, and it's just not done anything. And if so, what you need to be thinking about, which over-the-counter agent did they use? Because if they use clotrimazole or miconazole, which are the common ones available here, these also get Candida. But there's that tonaphtate, and so that one they may use, which is in the over-the-counter sprays or lotions. it won't get, it only gets Taenia. It doesn't get any of the other yeast like Candida or fungus like Candida. All right. So between which toes is Taenia most likely to develop? First and second, second and third, third and fourth, fourth and fifth, or fifth and sixth? What do y'all think? Okay. All right. You're actually voting. That's great. Okay. Short-term memory here. Good. 80. So 11% of you, well, the 7% I'll give you a break because you're from Jersey Shore. But anyway, all right. Okay, spore tricks. All right, this is my shining moment when I took my initial test, supposedly, because I can't talk about it, right? Although I don't think we had an honor code back then. We probably did. I don't know. If we did, it was written in stone, you know. Anyway, there were some tests I took, and there was some question, and they were presenting spore tricks, supposedly. And I was so proud of myself because I figured out it was going on. And anyway, I'll get to the why I was proud in a second. But so you get these patients get exposed to this fungus in interesting ways. Usually it's gardening. Okay, that's kind of the big thing. And they get this nodular lesion at the site of the inoculation. It ulcerates. They get this nasty looking ulcer. And then upstream from that, in the lymphatics, they get these nodes. And I'll show you pictures of it in a second. And these are the different things. So look out for the kid who's a farmer, okay, who works on a farm and maybe working with straw or hay or corn husks. Or it could be a gardener or some kid who's working in it part-time in a florist shop, okay, with roses, things like that. So these are the kind of environmental exposures that are important. Or they're an immigrant kid and they go and pick berries every year with the family during harvest season. So you get the single lesion, it ulcerates, and then they get these nodules that develop, and it progresses. And so commonly what happens is people have been, well, I don't know what it is. Let's just treat it with Keflex and Augmentin. It doesn't get any better because it's not a bacteria, it's a fungus. And you diagnose this by culturing it. So you go in the lesion, you just culture it. And this is my shining proud moment. So at the time when I when I was taking initial certification test, SSKI was the drug of choice, okay? And it's not used for anything else, ever. So it was just like, wow, I remember that. I was so proud of myself for remembering it. So question A, part A had SSKI in it, just saturated solution of potassium iodide, but it was listed as topical. And E was oral. Well, I didn't see the E. I just stopped at A and said, oh, SSKI, that's it. So be careful if I don't think they'll still have it on there, but it's oral SSKI, not topical. So you don't drop it on the lesion. Okay. Now here's the stupid way this drug was. So this is actually out of the PDR. This is how you use this drug. All right, this is how you start. You do 5 drops 3 times a day. You increase it by 1 drop a day. So you do 5 drops 3 times a day today. Tomorrow you do 6 drops 3 times a day. The next day you do 7 drops until you get to a total daily dose of 120, 150. Okay. I've treated a few patients with this before. Most of these patients are like 80 years old. Okay? And I'm just like, okay, just take a teaspoon 3 times. I don't know, Okay. So you use it orally. Now, the key is today, itraconazole is a drug of choice, okay, Sporanox. So if they're going to give you this, I would think they'd give you itraconazole Sporanox as the drug of choice. If they're bad sick, you're going to pick amphotericin B, okay. So the other clue, or the other thing here, just to mention as an aside, but to help you on the test, if it's a fungal thing and they're not that sick, you're probably going to use, and it's like something, like Blasto or Histo or Sportrix, you're going to generally use something like itraconazole if they're not that sick. Itraconazole or Sporanox. Okay. If they're bad sick, just pick amphotericin B, and you'll be right for funguses. Okay. Pretty much for your test. All right. So here's the lesion here. So this is obviously hopefully a man, older man with his hairy knuckles, but anyway, had the rose bush thing, and this goes up the lymphatics of the arm, okay? So that's Sportrix. All right, so here's a little joke thing. How to pass the test. Study, yeah. Pray, okay. Pay them some money, okay. And this is how surgeons prepare for boards, okay. The oil can and clunk. Okay. All right. So it's pediatrics. So unfortunately, we have to spend some time on parasites, okay, because some of these are pretty common, some of these are not, and you know how the boards are. So, all right, so let's talk about protozoa. So protozoa are single-celled organisms, okay? The deal with these little things is that they can replicate in our body, okay? They can reproduce. What's crazy about it is they're reproducing in there, but we just ignore them. We don't make eosinophils against them. Okay, so they just go along. And so we're going to talk about these first. So these are the ones that we just kind of okay, just stay there, it's all right, whatever. So the first one I talked about is Cryptosporidium. Okay, so this is a classic, outbreak that occurred in Wisconsin years ago now, and you get this watery self-limited diarrhea. So on the test, what I'd be looking out for is they start talking about a community-wide outbreak of diarrhea. It's like the whole town. You're seeing the whole town is coming in with this diarrhea. Okay, all ages, the parents are sick, having it, the kids are all sick, the adolescents are sick, the little 2-, 3-year-olds are sick. It's just all over the town. So it's classic community-wide outbreak. Something got in the water supply. Lasts 1 to 2 weeks. And you can, if you want, you can treat them with a 3-day course of this oral suspension. Most times you can just leave them alone. They'll get better. But now we have this newer drug that's a suspension, so we can use it in pediatrics, and it works pretty well. If they're immunosuppressed, so it's an HIV kid or a kid who's got an immune deficiency, then you're probably going to have to treat. And generally, because they're going to have persistent disease, and the recommendations are these drugs, and I really would not worry about the drugs. I think what they really want you to do is figure out what the organism that's causing the community-wide outbreak. So just know Cryptosporidium. You diagnose it. Now we do this Cryptosporidium antigen test on the stool. Okay, you just do a stool antigen test. Okay, and that's what it looks like if you do an acid-fast smear. All right, Cyclospora, this is kind of the new kid on the block, the new acid-fast diarrhea causer. And this was really big in the 90s, and they keep having outbreaks, and it's here in Texas. Okay, it's in Houston, Corpus Christi area, and what happens is raspberries or strawberries are brought in from Central America, Honduras, Nicaragua area, Costa Rica. They come in and they have this protozoa on it, and people get diarrhea from it. Okay, so that's the geography on that one. It's going to be people have eaten raspberries or strawberries from Central America, generally Texas, and this is it. This organism, acid-fast again. All right, malaria. There's really 5 types. I didn't put the 5th one on because it's not even worth talking about really. But P spores sometimes ask crazy things. Just remember, this is a mosquito. This transmits this one. So this is a mosquito. So we talked about the flea with plague. Almost everything else we talked about was a tick, and now we have a mosquito here. All right. So this shows you where malaria is. So all the red are the areas we worry about. Yellow, some parts. And notice in the States, Mexico, Central America, and then here, Haiti, we had, a lot of cases occur after the earthquake. All right. So malarium falciparum, this is the most fatal, the one we worry about. The key thing with this one, if they talk about it on the test, just know chloroquine's not going to work. Okay, yes, there's still pockets where it's okay, but for your purposes on the test, if they talk about, if you see falciparum in the question, just know that you're not going to use chloroquine. You need to think about something else. And they may just ask you about, is this going to be chloroquine resistant? You say yes. More than likely it's resistant. They haven't done smears in years, I don't think, but if they decide to do it now because it's on computer and it'd be cool to have a smear pop up, I don't know what they're going to do to y'all. But banana gametocyte was a classic thing. Okay, banana. I'll show you a picture of that. Or if they show you red cells and there's just tons of organisms. And remember, this is an RBC disease, okay, red cell disease. So they're going to see lots of red cells, and you just need to look for little bugs in there, little organisms. Treatment, I really wouldn't worry about treatment of the active disease. I mean, in pediatrics, it's going to be really rare that you see cases, and so they're going to know that. They just want you to be able to identify it's there, and then call somebody to help you with the therapy. All right, Vivax, they used to love to add, this is like a step 1 thing, is the Duffy RBC antigen. I don't think they'll waste a question on this anymore. Now that's down to 1 day, but this is one of the things that they might have asked about. And then malaria was associated more with the nephrotic syndrome. Okay, these other ones, they generally are sensitive to chloroquine still. But what you have to remember is with the Vivax and Ovali is you have to use Primaquine too. Okay, because you need to eradicate the organisms that are hiding out in the liver. This is really easy to remember. Okay, VO is vodka. So VO, vodka goes to the liver. So Vivax and Ovali, VO is vodka, goes to the liver. Okay, and those are the ones that relapse, those two. So you need to use Primaquine. So they show you a smear with a bunch of red cells, and the patient's got this hemolytic anemia going on, and they've traveled to Africa, then just pick malaria, okay? I mean, there's not much else that's going to do it. And then all you see is you see these organisms, all these different organisms. And if you see multiple red cells that are infected, you know it's falciparum. I mean, there's nothing else that's going to give you so many red cells that are. Usually it's very hard to find malaria on a smear. So if they're going to show you a smear with it, it's got to be falciparum because that's the one that's going to have all the different, lots of red cells or red cell with multiple organisms in it. Here's your banana for you. So if you see the banana. All right, little tidbits as far as prophylaxis, and this you probably do need to be aware of, okay? This is because a lot of your patients, particularly adolescents, go on mission trips, and they go over to places where you worry about malaria. So they might ask you about this. So what you need to realize is for the most part, you're not going to use chloroquine. Okay, chloroquine's not going to be used for most of these kids going to Africa or Asia for sure. And then you need to choose which one. And so a lot of it depends on the side effects that they don't want to have or on how soon they're going. Because some of these you have to start weeks ahead of time. Others you can start the day before. So let's kind of go through this. So mefloquine, okay, mefloquine, what you want to do is you want to start it once a week for 3 weeks before you go and continue for 4 weeks after leaving the area. Okay, so 1 to 3 weeks, once a week you take it for 3 weeks before you go and then go for 4 weeks. Now you can do it as early as 1 to 2 weeks before, but the guideline prefers this, and so for the test, just know if they give you a kid who is coming to you, classic teenager, hey, I'm leaving for Africa in 4 days, what do I need to do about that? Know that you're not going to use mefloquine. Okay, the other thing, remember, is you don't want to use this drug in someone who's got a history of psychiatric illness, okay, and you don't want to use it in someone who's worried about having really, really bad dreams because this makes you crazy. Mefloquine makes you nuts. So a lot of people do not like this drug, okay. It's probably one of the least favored of the group. It also makes everything taste bad. Okay. Doxycycline, this is good because you can start it 1 to 2 days before you go. Okay? But you got to keep taking it for 4 weeks after, and you got to take it every single day. All right. So the problem with that, adolescents is, well, adults too. So you go on your trip to Africa, you take it, and then you get home, and what's the first thing you do? You just stop taking it. You say, oh, I'm back in the United States. I don't need to take it anymore. Well, the problem is you probably still have, if you've been infected, you've got malaria organisms inside of you replicating, and it takes 2 to 3 weeks to get rid of them all. So you got to keep taking it for 4 weeks after you get back. So the most common reason we'll see people have malaria when they come back is because they stop taking their prophylaxis too soon. Okay, so this is another one you got to take for 4 weeks every day. The other problem, so the big problem with doxy is sunlight, right? So they're going to Africa and they're outside all the time. So they really got to use a lot of sunscreen, okay, which again, we're talking about adolescents. So just think about, when you more real life stuff than the boards. The last one here, atovaquone, proguanil, or malarone. It's nice. You only need to take it 1 2 days before you go, and you only need it for 7 days after you get back. Okay. The bad thing about this one is the cost. It's expensive. This is cheap. Doxy's cheap. This is expensive. Okay. So in the question, if they give you more than one of these as a choice, they're probably trying to give you, they look back and see is there any reason not to use it. Okay, not like they say the patient is, has bipolar, where they don't want to give them mefloquine, or the patient, has, some kind of skin disease that if they get sunburned, or that you don't want to use it. Okay, so you wouldn't use doxycycline for that. So anyway, Malarone really isn't a problem. It's just the expense is the problem. That's the biggest problem people have. Okay, now here is malaria in the United States, essentially. So Babesia is kind of like our version of malaria, okay, except it's transmitted by tick. Okay, this isn't done by a mosquito, it's by a tick. You get a febrile hemolytic anemia. I'll show you this Maltese cross pattern. It's kind of classic board fodder. They like to show this. Commonly seen in the Northeast. So we're, again, with Lyme disease, where you have Lyme disease, and where we have that anaplasma, okay? And it's not uncommon for patients, so with tick bite, remember, they get the anaplasma with the tick bite, so they get this pancytopenia. They also may have Babesia too. It's not uncommon for patients to have a dual infection with Babesia and anaplasma at the same time. One of the predominant signs is hemoglobinuria, okay, so hemoglobinuria. And supposedly emotional lability is common with this. So again, if it's an adolescent, it's kind of hard to tell sometimes, right? All right, mild disease, I give you the treatments. I don't think they'll ask you treatment. I think they just want you to diagnose it, okay? So they may show you a smear, and they'll show you, you'll see there's tons of organisms in here, in these red cells, but this is the Maltese cross here, okay, that one right there. So if you see that, that means they've got, this is Babesia. Okay, amoeba, this is again generally going to be geography to help you. So Texas is probably one of the more common places, particularly southern Texas on the exam. This is fecal oral. You can see it in immigrants, described more commonly in gay men or people who are in jail. The big deal about this one they like to present are two things. One, okay, if you've got the diarrhea, then you can just do a stool test looking for it. But generally what they'll do is they'll have this patient who shows up, and for some reason they've had this ultrasound or a CAT scan, and they're from southern Texas, and they've got this right here, okay? And then what they want to know is, how do you diagnose this? And so the key is you want to do serology, okay? So you want to take blood work. So do a amoeba serology. Into amoeba serology. If you aspirate it, you wouldn't find any organisms there. If you check the stool, by now you're not going to find any organisms there. So you need to do a blood test looking for an antibody serology. Treatments, metronidazole or flagyl, and then you also need to use one of the luminal agents. Again, I don't think they'll ask you about that. I think they just want you to identify it. All right, Giardia. Okay. On this one, geography-wise, this is where Rocky Mountain comes in. Okay. So someone who's been to Colorado or Montana, or Idaho, they've been fishing or they went camping with family and they drank from the pristine waters, and now they come in and they've got this horrible, stinky diarrhea. And they may even say they may even say in the question sulfuric belching. If they say sulfuric belching, they have Giardia, okay, on the test. You can do, generally what you want to do is Giardia-specific antigen, okay, which is the most accurate test now to do. How many people here have done the string sign, the string test? Anyone? A few of us? Okay, so a few of us grayer-haired maybe, or young people. But that was the most disgusting thing I've ever done. So anyway, you put the string down with this little capsule thing, and then you leave it in overnight, and then you pull it out, and you can find the Giardia there because it's in the duodenum. They hang out in the duodenum. So it's really bizarre. But anyway, now you just do a Giardia-specific antigen, okay? The treatment, there's suspension forms, and I mention these because metronidazole is what we've always used, right? Metronidazole, but it's not FDA approved. And the boards, it probably still is the right board answer, okay? But they may get rid of it because it's not FDA approved because they're trying to be all uppity about FDA approval now. And so they may give you, if it's a older kid that can swallow a pill, this thing works great. Tinidazole, which is a single dose tablet, is approved for kids older than for 3 and older if they can swallow a pill. If they can't, we've got suspensions of these newer drugs as well. I think they'll still give you Flagyl. It works. We know it works great. It's cheap, okay? So it's probably what they'll give you as the answer. But if it's not there and you're sure, if they say sulfuric belching and you look for metronidazole is not there, then look for one of these drugs. And here's the happy Giardia swimming in Colorado. All right. I mentioned this because of Chagas disease, okay, from South America. Back in May of this year, well, actually before that, so what's happened is there's like this epidemic of Chagas disease that is rumbling up from South America. Supposedly it's going to be here in the States pretty quickly. There's this big concern that this is the next big epidemic here in the United States, is Chagas disease, because it keeps getting further into Central America, and eventually they think it's going to be here in the States as a major problem. So the boards may pick up on that, so just be familiar with some of the things with this. So it's due to this organism. It's usually self-limited, but patients can develop problems from it. I'll show you this Riemannia sign, which is more commonly seen in kids. So this is what they may show you. They probably show you this one kid because it's the only picture you can find on the CDC website. So anyway, so they'll show this poor girl. The big thing with this is you get heart block, okay? So here's an infection that causes heart block. So we already had Lyme disease cause heart block, and here is Chagas disease causing heart block, okay? So two things. So just be aware of that. And this is the Riemannia sign, okay? So you get the edema, really thick edema. All right, so now let's switch to worms. So multicellular worms, these don't replicate in the body, okay? So they just sit there, but they do cause eosinophilia. So you're going to expect to see, if you did a white count on these patients, they'll have a high eosinophil count, okay? So here's the kind of the big list that we like to talk about. So the roundworm, is Ascaris. You get the Loeffler syndrome, where the worm, we're not the natural host. It's trying to find the natural host, which is in us. And so you get these shifting infiltrates on a chest X-ray. It's kind of classic what you'll see with this. You also can see that, remember, with Toxocara, which we'll talk about on, I think tomorrow we'll talk more about that tomorrow with the zoonoses. Pinworms you're all familiar with, the Scotch tape test, mebendazole or albendazole is the newer drug that's available. Mebendazole is going off the market. Vermox is gone. So here's your new treatment, okay, albendazole, okay. Hookworm is that classically what you'll see is someone who lives in the South, and they'll show you a foot, and they'll show you this, looks like they'll just say, you see where this worm has been crawling around in the foot, okay? And they'll show you, you'll kind of see the tract with this. So cutaneous larva migrans is hookworm. Whipworm is diarrhea, abdominal pain, rectal prolapse. And then trichinella is from eating pork that's not properly cooked. Okay, and again, we'll spend more time talking about these tomorrow with zoonoses. Here's some beautiful Ascaris for you. And occasionally they want you to just know what these stupid eggs are, okay? Like you're really going to go do a stool and look for these eggs by yourself, okay? But anyway, this is the classic one. Remember the football? This is the classic one that people remember. I doubt they're going to give you this anymore. I just don't think they're going to do that. They know you can't do it in your office. It's against the law, right? Doing kind of lab now. It's like, oh no, don't do lab in the office, All right, here's cutaneous larva migrans. Okay. All right, strongyloides. This is important because there's a lot of data in kids about this thing. about how common it is in pediatrics. So the other thing weird about this is the only worm that replicates in the human body. Okay, it reproduces inside of us. They've done some studies in some rural areas of Kentucky. 3% of the kids are infected with this. Okay, so pretty common disease in the United States. Eosinophilia is prominent. It can go on for decades, and really it's not a problem. It's only a problem if you get immunocompromised. Okay, so once you're immunocompromised, you kind of keep it under pretty good control. But if you get immunocompromised, then the worm just kind of goes crazy and, disseminates. You've got lots of issues. So it's more of a problem in patients who are immunocompromised. The treatment is ivermectin or thiabendazole. This used to be the classic time. If you saw thiabendazole in an answer choice, you would just go back and look and see, is this strongyloides? Okay? So sometimes that's helpful for me. If I see this drug mentioned, which I still think they'll use this one, if they have that mentioned as the answer choice, go back and look for strongyloides as part of the question. Or if they say they were treated with this, then be thinking, okay, this is strongyloides is what they're trying to do. The weird one, again, it replicates in the human body. Okay, the pork flatworm, and this what happened with this is we had kids who were, we had some nanny come from Mexico or from Central America. So a nanny from Central or Mexico comes to New York, and she does cooking for them in the household and everything, and she's kind of a carrier for this worm, okay? So she's got the worm, and she's shedding the eggs, and it gets in the food, and the kids eat it, and then they start having seizures. And you do a CAT scan of the kid, and you see these calcified areas, okay? So this is neurocysticercosis. So there's some history usually of some immigrant nanny or cook who's come in, and now the kid has a seizure, and you do a CAT scan or MRI, and you find these calcified areas, and they say, what worm is causing this? And it's Taenia solium from pork, okay? And it's only a problem until the cysts die, and once they start dying, then they have seizures. So the kid will have a seizure, and you'll find the calcified areas. Right. I wouldn't worry too much about treatment, just more of identifying the bug. All right, the flukes. The big thing about these, if they're going to ask you, they're just going to ask you where it's going to be, okay? Because for some reason, again, these are scary words. So just remember Clonorchis. If you see Clonorchis, this is like, those of you that like sushi, go for it. This is the one that causes, the Chinese liver fluke disease. So it causes biliary obstruction. It's in the liver, okay? And then this schistosoma hematobium is the one that's in the bladder, okay? Those are only two I would really know from this slide. Just know where they go, liver or bladder. Okay. All right, let's switch to something you're much more familiar with, okay, viruses, which you all love. All right, so let's do this case. This is Roxanne. She's admitted with a sickle cell pain crisis. Yesterday, she was exposed to a cousin who had chickenpox. For some reason, Roxanne has not had varicella, and she's not been immunized against chickenpox. When should she be in isolation? So should you put her in isolation on admission? Days 8 to 21 after exposure, even without a rash. Days 1 to 10 after exposure, even without a rash. At the first sign of chickenpox, and then until lesions crust over, or at the first sign of varicella, and then until day 10 after the lesions have occurred. I know y'all hate this. Let's see how you do. Classic PEDS board. Okay, good. It's what I kind of expected. So B is the right answer here. B is in boy. The reason that, okay, you say, well, on admission. Well, the deal is the incubation period for this is about 10 days. Okay, so you're going to put her in isolation for the whole hospitalization probably, and she'll be home before, so she's going to be in isolation for 10 days. The cost of that, as you know, is exorbitant. She's got to be in a negative pressure room. and the air can't go out and all this stuff, and she's got to have gowns and gloves and masks and all this crazy stuff. So she's not going to be infectious until the day before the vaccinia shows up, okay? So the day before the varicella shows up is when she starts getting infectious. So what's the problem with that? Well, so the rash shows up today. Yesterday, she was in the playroom, and she was infectious, okay? So you can't do it at the first sign of varicella because they're infectious before they have the rash, okay? And so what you do is you have to go with, okay, what's the incubation period for this, and then start before the incubation period, and then keep them throughout the incubation period in isolation. So that would be B, answer B here. Days 8 to 21 after exposure. Even if she never has a rash, she's got to be in isolation during that time period. Okay? So primary infections, you all know, is chickenpox. We worry about in adolescents in particular, and you worry about in a pregnant adolescent very much. So if there's a pregnant adolescent on the test and she's got chickenpox, no, she's going to probably be bad. She's going to probably get pneumonia, and she may or may not need IVA cyclovir, depending on how bad she gets in the test question. Most people would treat an adolescent with oral acyclovir or one of the newer agents. Okay, the most common complication is going to be some kind of secondary bacterial infection, either with staph or strep, but most commonly it's going to be strep if they get toxic shock syndrome. So if they get toxic shock, it's probably strep that's the problem. They can definitely get skin infection, superinfection with staph, okay, but the toxic shock most likely is going to be due to strep. Remember the transient cerebellar ataxia that occurs with this, so they get wobbly. And incubation period is 10 to 21 days. Okay, so that girl had been exposed the day before, so you start. Day 8 would have been about the time that from the hospitalization when she'd be about at 9 days. So you start right before that. Now the deal is if they got Varizig, the immune globulin for varicella, say she was immunocompromised and we had to have her in the hospital and we gave her the Varizig, then what you need to know is you got to stretch it out to 28 days as far as the incubation period, as well as the isolation. And the red book says, I didn't look at the new one yet, but the old ones has always said 8 to 21 days after exposure. Okay. So here's classic chickenpox. The key thing here is remember it's going to be a truncal disease, truncal, and all the lesions are different stages, right? So you've got almost a scab over here. You've got a pustule thing here. You've got a little pimple starting here. So all the lesions are different stages of development. And when we talk about smallpox, you'll see why that's going to be important. This is a kid with ALL, with disseminated disease. So this kid would need to be on IVA cyclovir. All right, varicella in pregnancy. So varicella pneumonia, much more common in a pregnant woman. And here's some things that we just need to go over. And it was on your test, and a lot of you missed it. So birth defects, if the mom has never had chickenpox, so the mother is pregnant, she's never had chickenpox, she gets chickenpox during the 8 to 20 weeks gestation period, this is what we worry about, is this group of problems here. So the skin scarring, I'll show you a picture of that in a minute. Limb atrophy, small heads, cortical atrophy, seizures, chorioretinitis. All this stuff down here, yes, sounds like rubella. Okay? This is the part here, this first line and second line, is the part that is classic for primary varicella, that separates it out. If the mother is seronegative, you know she's never had chickenpox, and she's seronegative, you can give Varizig to her. It can be given within 4 days of exposure. But remember, we don't give her varicella vaccine. You want to give it before she got pregnant, hopefully. But unfortunately, she didn't. So this is the lesions that you see. Okay. All right. So here's pregnancy again. They like to ask about this. So the mom, okay, the mom develops varicella during pregnancy. If she develops it less than 5 days before delivery, or within 2 days after delivery. Okay, so mom develops chickenpox less than 5 days, so day 3 before delivery or at day 1 after delivery. Okay, then this baby should get Varizig. The reason is because the mother has formed no antibodies during this time. So if she develops it within less than 5 days before delivery, she hasn't formed good antibodies yet, or within 2 days of delivery, okay, she hasn't developed good antibodies. And so the baby is at very, very high risk. So the other thing is with this 2 days part here, remember the incubation period, right? So the baby is going to be, well, the mom would not have been varicella remic or whatever, would not have had varicella in her bloodstream at the time of delivery once you get past 2 days. Okay? So that's the reason why we don't worry about giving the baby Varizig after 2 days. Okay? So if she's in this window, then the baby needs to get Varizig. Treatment. The first kid in the house, we don't worry about. Second case, you can make there's some data saying, well, they're having a worst case, treat them with acyclovir. Pretty much, though, an adolescent or an adult you're going to treat. Okay, just give them the oral acyclovir or valcyclovir. A pregnant woman you're definitely going to treat, probably with oral therapy if she's not that sick. And then if you're immunocompromised or gets bad sick, use IV acyclovir. Zoster, remember, it can occur in normal host, and so generally it's going to be more commonly seen in adolescents. So I've given you the adolescent dosages here. They're not going to ask you about dosaging of these drugs. They know you're going to need to look that up depending on the kid's age. But just know you want to treat them if they get zoster because it will, especially the newer drugs, reduce postherpetic neuralgia. Okay, so the postherpetic neuralgia works as far as getting rid of it using the newer drugs, getting rid of it sooner. Prednisone we don't use anymore. So this is classic zoster. Okay, so if this boy, let's say he works at the supermarket and he wants to know, can he go to work? And the answer is yes, as long as he wears a shirt. So as long as the zoster is covered, they can be at work. Okay, so that may be a question they ask you about. Or he can go to school. Okay, as long as it's covered. Now, if he's a stripper, no. Okay, but if he's, and they may ask you about a nurse in your clinic. So if you get a nurse in your clinic and he or she has zoster, as long as it's covered, can be covered, then they can go be at work. Now, if you're a hemoc doc clinic, no. Or a bone marrow transplant nurse, no. But for the regular, just run-of-the-mill pediatric clinic, as long as it's covered, she can work or he can work there. All right, CMV. Asymptomatic infection is common. About 1% of all newborns are congenitally infected with CMV. So 1 out of 100 newborns have CMV. Okay? The deal is most of these kids, don't have any problem from it. Okay? So that's the good news. We know in daycare, 80%, CMV is just everywhere, right, in the daycare, right? So daycare, 80% prevalence of CMV. We really only worry about CMV in 2 cases. One, transplacentally infection of the baby, and then immunocompromised patients like our transplants or our AIDS patients. Let's talk about congenital CMV. The whole deal is if the baby's going to have a problem from it, really centers around, does the mom have antibody or not? If the mom has antibodies and the baby gets CMV in utero or late in the pregnancy or any time during the pregnancy, the risk of a serious infection is less than 1%. If the mom gets her first infection, though, during pregnancy, then you get the severe form, right? You get the blueberry muffin baby, the microcephaly, the cerebral atrophy, the hearing loss, the retinitis. And remember the calcifications, they circumvent, they go around the ventricles. So remember CMV, circumvent, it's a way to remember it, goes around the ventricles to help you differentiate it from toxo, okay, which is just kind of scattered throughout the cerebrum. Here, this is going to be surrounding the ventricles, so circumventing the ventricles. They get big spleens and livers. So here's where you would see the little arrows are showing you the calcified areas from the CMV. All right. In adolescents, remember, they can get a mono-like illness, right? So they get this mono-like illness. Classically, what will happen is on the test is they'll tell you, okay, you're really, you're pretty sure this is mono. You do the mono spot, it comes back negative. This is heterophile negative, which is what that means. So the mono spot is not positive, so it's heterophile negative, and this is mono, usually due to CMV. We worry about these organ transplants. I don't think they'll ask you about that. They're more likely to give you the adolescent who has, you do a monospot, it's negative, and they go, and it's not strep because they've got these other URI things, and they want to know what is it, and you think, okay, it's got to be CMV. I've given you the treatments. They're not going to ask you about this. Just know it's a bad, bad disease. If you've got a patient with transplant and they get CMV, it's potentially can be a huge problem. All right, EBV, remember, causes mono. Classically in the CBC, you'll see the atypical lymphocytes is what they'll describe. Half the kids, remember, get splenomegaly, and this is a classic board question. When can they go back to play sports? So no contact sports until spleen tip is not palpable. So their recommendations are you keep bringing them back, and you keep feeling, see if you can feel the spleen. So hopefully you felt it the first time. The other thing which reminds me, on the test, you are outstanding diagnostician. Okay? So they tell you the spleen tip is now gone. You go, okay, I believe myself on the test. You can go back and play football, or you can go play girls lacrosse, or whatever that you're doing. Okay. Okay, the monospot. It's important to know this information here. So if most kids who are older than 4, it's going to be positive. If it's a 2 to 4-year-old, only about half are going to be positive, and it's less than a 2-year-old, it's less than 10%. So my take home here is you're probably not going to check a monospot in anyone that's under 4. It's just not going to be helpful. If you really think it's EBV, there's something going on with EBV, you want to check specific tests for that. If they're older than 4, then definitely you can do the monospot. Usually it's going to be an adolescent, and like I said, usually it's going to be positive. The other thing about EBV, sometimes they'll ask is it's associated. Here's a virus that causes cancers. Okay, we know it causes cancers. So African Burkitt lymphoma it's associated with, B-cell lymphoma. We know it causes hairy leukoplakia in AIDS patients. Most people who get EBV are asymptomatic, which again can't be a board question. Okay, so they're going to give you symptoms. The deal again, this virus persists, but this time instead of being like in nerve cells, it's in B lymphocytes. Okay, so it persists in our B lymphocytes. So the B lymphocytes are made, and the virus keeps persisting there. The problem is that you got some kid who had this, and now they go get it transplanted. They've got an increased risk of having this lymphoproliferative syndrome with EBV. All right, so classic sore throat. I couldn't tell you from looking at this, is this strep or EBV? I mean, nobody can. Okay, nobody can. Classic case here. So here's a kid. So the other thing is on the test, if some other doctor or some other nurse practitioner has done something, they're an idiot. Okay? They've probably done something wrong. So here's this kid, went to see some other doctor, all right, and they did a rapid strep, and it was negative, and they go, well, I really think it's strep, and I'm not going to weigh on the culture. I'm just going to put you on ampicillin. Okay? And then the kid comes in with this rash. Okay? So that's one classic way they'll do it. This is all like this because the kid tried to shave the day before, and for some reason it came out really, really heavy there. So anyway, it's called the shave sign for EBV. I don't know. Okay. Now, the antibody stuff, right? And you're just like, oh, gosh. I see it, and I know your eyes just glaze over because it's IgM, IgG, Vika, EBNA, EA. All right, so let's try to make it as simple as we can here. All right, so if you see for any disease we talk about ever in infectious disease, if they say an IgM is positive, that means acute disease. Okay, if there's an IgM positive for any disease, they have acute infection with that. Just pick it. Okay? Don't worry about anything else. If they say an IgM test is positive, then just pick it as acute, and you're right. Okay? Just pick it. This EBNA, if they are EBNA positive, all that means is they're probably convalescent and they're post the infection. So EBNA just means they've had it. Okay? And they're convalescing. This IgG is useless. IgG tests generally are useless. All it tells me is you have a positive IgG, you've been exposed to it, got infected with it, and you may still be infected with it or you may not, but it stays with you for life. It doesn't help you at all. So particularly for EBV, IgG doesn't help me at all. It can be positive and acute, it can be positive and delayed. It can be positive that you had it 30 years ago. The EA is not very helpful either, so I would just ignore it. The main thing you want to look for in the test is a positive IgM. If they say that there's a positive IgM with something with EBV, that's just telling you they got active acute disease. Just pick it. Okay? If they say EBNA, then just say, okay, it's convalescent. They may have had it recently, but they're getting over it. So the bottom line here, IgM means acute or very recent infection. And if all they have, all the testing comes back, and there's just an IgG there that's sitting there all alone, it means that they had some infection a long time ago or sometime. All right. Okay, a college student presents with cough, coryza, conjunctivitis. His parents didn't believe in immunizations. A red rash now develops. What's the most likely cause for his signs and symptoms? Rubella, measles, German measles, acute HIV, or human herpes virus 6? What do y'all think? Okay, good. So good pediatricians. You knew this was measles. So the 3 C's, cough, conjunctivitis, and coryza, that all goes with measles. Rubella and German measles are the same thing. Okay? Rubella, remember, is a big lymph node with the rash in the back, occipital lymph node. Acute HIV we'll talk about. In human herpes virus 6, what's that? It's roseola, right? So it's a little baby disease usually. All right, so human herpes virus 6 is now known to be cause of roseola. Human herpes virus 8, we know, or think we know, is responsible for most of the Kaposi sarcoma. Okay, rubella or German measles. So the big thing about this on the test is not probably that you're going to diagnose it in an adolescent. With rubella, it's that there's going to be a mother who somehow got exposed to it and wasn't immune. And so they're going to ask you about what are the problems with that. So let's just go through this. So with congenital rubella, so if she gets infected or has rubella in the first trimester, then the kid is going to be affected. And you can just guarantee the kid's going to be affected. And this is the kind of kid who's going to have the classic rubella syndrome with cataracts, cardiac disease, glaucoma, hearing loss, and neuro problems, okay? So early disease is likely to cause significant bad things for congenital rubella. If it happens in the second trimester, then they've only got a 25 to 30% risk of getting infected. So actually the kid likely is not going to be infected. Okay? If they do get infected, then they have some risk of hearing or neurologic problems. Okay? If it's the third trimester, they're pretty much between 60 and 100% all going to get infected in utero, but there's not going to be any sequelae from it. Okay? So the kid will have rubella inside the mom and won't have any long-term problems from it if it happens during third trimester. So what you worry about with rubella is the first trimester in general. That's where you worry about if she gets infected during that time period. All right, here's the classic cataracts. And this is what it looks like in a older kid. So big occipital lymph node. They showed you that. All right, rubella. Wait, that's not. This is the kid who's got measles. I'm sorry. Okay. I just can't see his eyes. All right. All right. The other thing with rubella that you want to be worried about is, with rubella is are these things here. And this is, I think, very important, is that kids who had congenital rubella, they have a risk of insulin-dependent diabetes that's 4 times normal by age 10 and 10 to 20 times normal by adulthood. So whatever it is, the pancreas doesn't like rubella, I guess, in utero. They also have an increased risk of thyroid disease. So I would know both of those. So remember, diabetes, insulin-dependent diabetes, and thyroiditis is something to look out for. So the kid may look fine, didn't have any problems, but just realize over time you need to follow them. They have an increased risk of diabetes as well as thyroid. All right, measles, cough, coryza, conjunctivitis. They get the rash. It begins at the hairline and goes south. They have the Koplik spots. Remember, and this is important, I think, for the test, it's more severe in those who are vitamin A deficient. So that's why we have such a big problem with measles in Africa, because they're commonly, these kids are vitamin A deficient, and they're more commonly going to have severe disease with measles. If you have an immunocompromised kid, or even not immunocompromised, and you're trying to prevent the measles and they've not been immunized, you can give immune globulin, an IM shot of immune globulin, and that'll be effective if you can give it within 6 days of exposure. So this is classic measles here. All right, adenovirus. A couple things about this. Common cause of a respiratory infection. The classic thing you see is a swimming pool. So on the test, look out for summer, swimming pool, conjunctivitis. Okay? Swimming pool, summer, conjunctivitis. Everybody's got conjunctivitis at the swimming pool. All right? That's adenovirus. You can also get a diarrhea due to these types. It may be responsible for increased risk of intussusception. Right? So they possibly could ask you about which virus increases your risk of intussusception. If you have diarrhea with it, it's adenovirus. And then the other weird one is the acute hemorrhagic cystitis that's seen with adenovirus. In 2011, military recruits are given, there's a new live oral vaccine, so they're the only ones getting this vaccine. It's only good against 4 and 7. Okay. All right, SARS. I mentioned it briefly just in case it shows up as a distractor maybe. Remember we had this huge outbreak in 2003. Had a lot of children affected by it. And the only thing on the test I guess I'd worry about is they had recent travel to Asia, or they were said Toronto. They talked about Toronto, Canada. It's the only reason I think they mentioned Canada in a question is this SARS business. And the weird thing about this virus was, so you get fever, chills, you say, okay, whatever. But then the crazy part was the respiratory symptoms often didn't appear until 2 to 7 days after the onset of the illness. Okay, so they got sick, and then it was like this delay before they got their respiratory symptoms. And they commonly had diarrhea with it first. RSV, you all know really well. Kim will spend more time on RSV and pulmonary, talking about that, particularly the monoclonal antibody prophylaxis. She'll cover that in her lecture. And then paraflu, we talked about, remember, it causes croup, and we want to use dexamethasone for croup to get the shot. And Kim will cover this in detail in her lecture. Flu, I think for the boards, they're probably not going to ask you much about it, except you just know you need to immunize. You immunize everybody. Okay, everyone gets the immunization for flu. Okay, enteroviruses. These are all enteroviruses here. The Coxsackie virus, Echo, enterovirus, and polio. Hand, foot, and mouth disease. You get fever. You get the vesicles on the buccal mucosa tongue. They'll likely show you either a hand or a foot with these mouth lesions. Just know it's due to Coxsackie virus usually. So here's the lesion here on the tongue. So they'd show you that, and then they'd show you hands. And if they showed you feet, it's like, okay, thank you for being easy on this one. All right. Other enteroviruses here, herpangina, remember, is from Coxsackie virus as well. And here you get, so this is where they get tricky, because you have to remember, separate these out from herpes and herpangina. So herpangina is due to Coxsackie virus, and it affects the anterior pillars of the tonsils, uvula, and pharynx. So you look back there and you see these tiny little vesicles on the anterior pillars of the tonsil, the uvula, and the pharynx. They're very tiny and they have a sore throat. Remember myocarditis we can see with Coxsackie virus as well. And here's what you might see, okay, on the pillars. Okay, polio. Again, we don't see this in the United States. If we do, it's because of usually an immigrant that's come into the country with it. The big deal here is that this is a proximal disease and then it spreads distally. So don't get confused if they talk about this and think it's Guillain-Barré. Remember, Guillain-Barré starts distal and comes proximal. Okay, so don't get that confused with poliovirus. So the case definition, you have to be under the age of 6. This is the World Health Organization case definition, under the age of 6. Fever when the disease starts, a descending paralysis with the maximum extent within 4 days, and then they have to have neurologic deficit for longer than 60 days. And you can culture from everywhere, stool, throat, spinal fluid. And then there's this post-polio syndrome that we're seeing in adults now and people who had polio as a kid. I don't think they'll ask you about that. Mumps, a couple things with this, because as you know, we've had these huge outbreaks in Iowa, in New York, over the last several years, so they're likely to ask you about this because we see it again. Remember, the big problem we worry about in boys who are post-pubertal is epididymoorchitis. Okay. Know, though, that in women, and maybe the boards will get, with it and ask about them because they have a really high incidence of mastitis, and they can have oophouritis too. So just be aware of that. They might ask you about, they'll say, oh, everybody knows about orchitis, but they probably don't know about mastitis or oophouritis. Deafness is seen in about 4%. The other thing, though, if you see a big parotid gland and it's an adolescent patient, have in the back of your mind bulimia, particularly if they don't have fever or something else like that going on. So this is this poor kid. Okay, so when we had the outbreak, this is a CDC stock photo, and this kid was just plastered over everywhere. CNN, Fox News, and this is me as a kid, and I'm suing. Kind of looks like I did when I was a kid. So anyway, wherever this child is now, he's famous. All right, Parvo B19. Here's like 3 questions here. So first thing is you need to know classic fist disease. Okay, erythema infectiosum is the fancy name for fist disease. The big news they may ask you, or the big test question for this is you've got a kid, they've got the slapped cheeks, right? The slapped cheeks and the rash on the arms. It gets brighter in the sunlight or when they take a hot bath. Once the rash appears, they're not infectious. Well, you don't know they're sick. Generally, they have some fever beforehand, but you don't know what's going on, and they keep going to school, and they keep going to daycare or whatever, and then the rash appears, and they say, oh, let's take them out of school. Well, now they're not infectious anymore. Okay, so once the rash is there, they're not infectious, they're fine, go back to school. Remember, what we worry about are our patients because this virus infects red cell precursors. So a sickle cell patient could be in big, big trouble here. If they get parvo and they can't, remember the sickles are turning over the red cells really, really rapidly, much more rapidly than our 120 days. And so if they that just stops abruptly, they're going to get into a big aplastic crisis, okay, and get into trouble. So that's a classic question they might ask you about. We see it also in our HIV patients as well as in leukemics. We can see it. But the classic one on the boards is sickle cell patient. The other thing is they may give you an adolescent or a mom comes in of a child with this history of this rash, and she complains of hand polyarthritis, okay, small joints, arthritis. Adults may have the rash, about half do. Most of the time, though, on the test they don't, and they give you some history of this kid had this rash. It sounds like fist disease, and now the mother comes in or an older adolescent and the family comes in with the polyarthritis of the hands. Okay, that's a classic way to present. Pregnancy we worry about. Most infants who are exposed to parvovirus are normal, but there still is a small chance that 5 to 10% will have fetal loss because of high drops. Classic board question there. Diagnosis, you can do an IgM antibody. So again, a positive IgM means they have active parvo. Here's this cute girl. I almost covered up her slapped cheeks here. And this rash, and the classic story you'll get on the test is they'll say when she's outside playing, the rash is really, really bright. Or I put her in the bathtub with warm water and it comes out really, really bright. That's classic for parvo. Okay, hantavirus. This is where you mainly going to look for someone who lives in the desert Southwest. It's an adolescent with severe hemorrhagic pneumonia. Now, what do we talk about already that has a hemorrhagic pneumonia from the desert Southwest? Plague. Okay, so plague pneumonia can also. So this one can be tricky. The key thing here, what's weird about hantavirus, is that the hematocrit is increased. So they have a high crit in their blood, but they're throwing up, or they're coughing up blood. So coughing up blood with a high hematocrit, think about hantavirus. Desert Southwest. Again, exposure to rats, rat urine again. Okay, favorite slide. Reserved for the 8. This was at our VA. So that the vets would, slide down with their Foley catheters. Okay. All right, a few syndromes here. Okay, endocarditis. How do we diagnose it? Blood cultures. Blood cultures, blood cultures, blood cultures. Okay? If it's negative, you think of these things: Q fever, Legionella, chlamydia. They took those haystack things out, the Haemophilus, Arcanobacterium, I forget all of them, Eikenella, Kingella, because now we can grow, our blood culture methods now grow those. Okay? So if it's culture negative, it's not the haystack. So it's not Kingella, it's not Eikenella. You can always grow those now pretty much in blood cultures. It's going to be something weird like Q fever. So, and then Dr. Pickoff will spend a lot more time on endocarditis. Meningitis, big topic here. So let's start with a question, kind of wake you up. 18-year-old college student presents with signs and symptoms of bacterial meningitis, and LP is consistent with a bacterial infection. She works in a daycare. Okay, that was pretty good. Let's try one more time. She works in a daycare. Good. Okay. Which of the following is the correct therapy for her? No antibiotics, await culture results, start IV ceftriaxone, start IV penicillin, start IV vancomycin for resistant pneumococcus, or give her IV ceftriaxone and IV vanc. So what do y'all think? Okay, good. Very good. So the daycare thing is thrown in there because why? What are you worried about in daycares? Resistant organisms, right? And which organism in particular? Pneumococcus. Okay? So the most common cause of bacterial meningitis in the U.S. is pneumococcus. Okay? Strep Pneumo. So she's in a place where there's likely to be resistance. All these kids are on antibiotics. They're all over the place. And so you worry about resistant organism. So ceftriaxone for sure. We're always going to use that. But you add the vanc now. Every empiric therapy for bacterial meningitis in the U.S. should be vanc and Rocephin or vanc and clafuran. So vanc and ceftriaxone or vanc and cefotaxime. Okay? Ceftriaxone by itself is no longer recommended. Okay? So make sure you know that for the test. Look for that. All right, so what is meningitis? Inflammation of leptomeninges. If they're older, in our older patients, they get the fever, headache, stiff neck. In the neonates, they don't have any of that. They just may have lethargy or irritability. Encephalitis is actually an infection of the brain or inflammation of the brain, so they get weird behavior. They have seizures, focal signs. And then meningoencephalitis is just inflammation of both. So your history is important. Your physical is important. Poor history and physical will get you here. This guy didn't get into medical school. And you're left like that. So the important things here on the test are, in little babies, y'all have no trouble with this. You tap them like crazy, right? Neonate, let's just tap them, okay? But if a 16-year-old comes in and goes, oh, let's get a CT scan, or let's get an MRI, and the answer is you don't do that. Okay, so let's go through this. So an acute presentation, doesn't matter their age. If there's usual symptoms, the classic symptoms, you think it's, it's meningitis. They've like had symptoms for an hour or two. They got fever, they got headache, they got stiff neck if it's the older kid. You do a real good exam. Remember, on the exam, you're an outstanding diagnostician. Okay, you can see papilledema. You can figure out if it's a non-focal exam or not. If all this is here, non-focal exam, no papilledema, nothing to make you think of intracranial pressure on exam, you go right to LP. Okay, I don't care if they're 18, 19, 20, 21-year-old, you go right to LP. And then when your pus comes back, you start antibiotics. Okay? All right. Now, this is different. Here is a patient who's had a headache for a long time. Okay? And let's say that this patient is got HIV. Would be the classic one where you see a chronic presentation like this. So there's an HIV patient who's had a headache for 2 weeks. Okay? Unilateral. They may have a neurologic signs or a seizure. And in these patients, they've been alive now with this for 10 to 14 days, right? So they're not going to die waiting on the CT or MRI scan. Okay? This patient back here, they've got acute symptoms. You send them to the CAT scan or MRI, well, and depending on what hospital you're at, that may be 6 hours later that they come back. Okay? Someone's on break or whatever. So this is acute. You can't, and the CT MRI isn't going to tell you anything. Your exam is telling you things are okay. It's okay to tap the kid or the young adult. This is telling you there's something bad going on. Okay, they've had this for 10 to 14 days. They got focal neurologic signs like a 6th nerve palsy. You need to get the MRI first before you tap that back. Okay, if the MRI is okay, then you do the LP, and then you base your therapy on that. Now, here's the problem, is if they give you somebody who's got the acute presentation, so they've had symptoms for a couple hours, but you see papilledema, or you see a cranial nerve palsy, or they have weakness on one side. In that patient, you're worried that they may have increased pressure, and so what you want to do is you give them antibiotics right away, and then you're going to do the scan when you can, and then you'll tap them later. The key thing here is, excuse me, you don't want to delay antibiotics. Okay, you don't want to delay antibiotics in acute presentation. Okay, so if you can't do the LP because there's something going on, then you need to give the antibiotics, get the CAT scan MRI, and then do the tap if it's okay. No one's going to yell at you for giving antibiotics where you got a culture because you're going to saving the patient's life here. All right, most cases of meningitis in the U.S. occur in kids. 3/4 of cases are before the age of 15. Strep Pneumo is number 1. Meningococcus number 2. Haemophilus is gone. Okay, this is new data that came out in New England Journal, okay, in 2011. So as you can see, what's number 1? Pneumococcus. Number 2, meninge. Group B, okay, our little kids, still there. Hopefully, as you'll hear in neonatology, we've lowered this maybe, with the prophylaxis that we're using now, and mom. H-flu, though, is still 4%. Listeria, okay. In older studies, back, in the 80s, in some areas, it was over 20%. Okay, so we're seeing a huge decrease in Listeria meningitis, thank goodness. But the point is that the big ones still are Strep Pneumo and Meningococcus. And Listeria we worry about in which age group? The kids less than 2 months. Okay, so we want to make sure, what do we have on board for them? Ampicillin, good. Okay, so why does this, what happens here? Well, the bacteria is in the blood first, and then it's got to get to the brain. Well, it's got to get across the blood-brain barrier, and these are the 3 features of the blood-brain barrier. Okay, and they've asked that, so I might just know what things kind of make up the blood-brain barrier. So arachnoid membrane, the choroid plexus, epithelium, endothelium. These are very thin things, but they work really well. So this guy is Arnold, well, the old Arnold, okay? And it's protecting the brain. Okay, so how does it get across the blood-brain barrier? Most likely we think it occurs at the cerebral capillaries and the choroid plexus. So something happens there at the choroid plexus. And then once it gets inside there, there's nothing to stop the organism from multiplying. And that's why things happen so quickly with meningitis, because none of our immune system is there in the CSF, because the point is we want to keep things out of there, and we keep our own cells out because we don't like having a lot of things in there that shouldn't be there. And then the bacterial products stimulate the production of cytokines, and then we have this huge problem. So what happens is the blood-brain barrier gets compromised. So with that, the transport systems are messed up. So with a bad bacterial meningitis, what happens is the serum proteins, okay, stay in the CSF. Okay, they're not pumped out. Okay, and the glucose doesn't get in. Right, so glucose isn't being brought in. And so what happens is that you get a high protein and you get a low glucose. Now, I know this is how you remember it, and go for it, and it's fine. You know, you think with bacterial meningitis, the bacteria eat the glucose. Okay? You remember that for the test. I don't care. So I'll help you even more. So the bacteria eat the glucose, so the glucose goes down, and they poop out protein, so the protein goes up. Okay? So bacterial meningitis, glucose is low, the protein is high. So it eats the sugar and it poops out protein. Okay, so you remember it that way, you'll be fine. Okay, it's not what really happens, but they don't care on the test. All right. You can also get, if the kid has had some kind of trauma, particularly the sinuses or the mastoid, you can actually get direct spread. And if that occurs, it's almost always pneumococcus. Okay, and they sometimes ask you about that. So if they've had some kind of trauma, and they keep having, particularly they have recurrent infection, is pneumococcus almost always. All right, remember complement with meningococcus, the spleen, the encapsulated organisms, sickle cell disease, the same thing, and HIV, you get the weird stuff. All right, don't memorize these numbers. Just all you need to remember is with bacterial meningitis, you get a lot of neutrophils. The glucose is low, the protein is high. That's all I'd remember. So it eats the glucose, poops the protein. Okay, viruses. Viruses don't eat, and they don't poop. So the protein is normal, and the glucose is normal with most viruses. Okay? So viruses are alive, but they're not eating anything, or they have no, excretory properties or whatever. Okay? The deal is the white count's a little bit lower, is a lot lower, and again, the glucose and the protein are normal. Now, the real reason, not because they don't eat, is because the blood-brain barrier is working fine. I mean, the mechanisms of transport are working okay. So it's not messed up. The virus is causing a little bit of problem there, but it's not messing up the whole system. So we still can get glucose in, and we still can get protein out. All right, TB is just like bacteria. Okay, so TB eats the glucose and poops out the protein. Syphilis is a little different in that generally the glucose is low, but the protein's also going to be low. Okay? So it's the one little different one. All right, treatment. We used to have to know this stupid table because initially when we started seeing all this resistance and you were trying to decide, well, should you use the cephalosporin or not, just ignore this. I wouldn't worry about this now. Just know we're going to use Vanc and ceftriaxone initially, and then when the sensitivities get back, you'll switch to whatever is least. If you don't need the Vanc anymore, you stop it. If you need the Vanc, you keep it going on. And they're not going to ask you to interpret these. These change over time, and so I wouldn't worry about these too much. All right, so any kid greater than a month of age and the gram stain doesn't show an organism, then what you want to start is a third-generation cephalosporin and vancomycin. If they tell you the gram stain shows something, then you know you need to do specific therapy for that. So third-generation cephalosporin and vancomycin is what we're going to start, because with the gram-positive diplococci, that means pneumococcus. Okay, steroids. The 2009 Red Book, which is what your test will be based on, is not committal about it. Okay, I haven't even looked to see what 2012, because I didn't want to confuse you. But for now, it's not going to be, it's non-committal. You can or can't, which to me means it's not on the test. Okay? If it's penicillin sensitive, they say it's pen sensitive, you switch to penicillin. Okay, least broad spectrum. Okay, gram-negative diplococci, that's meningococcus. You can use pen or third generation. Probably they'll give you third generation initially. The pleomorphic rod is H. flu. This is the one for sure you use steroids, and then you give the third generation cephalosporin. Gram-positive rod, that's Listeria. Ampingent is a treatment for that. And a gram-negative rod, you're going to use a third generation cephalosporin. All right, the sequelae we worry about is deafness. Okay, they'll probably ask you about that. What's the long-term sequelae from any bacterial meningitis? It's deafness. Prophylaxis we talked about already. When meninge for sure, household and intimate contacts. H. flu, some people. And then remember, rifampin is for H. flu. For meninge, it's rifampin for kids under 18. Ceftriaxone for the pregnant woman, and then Cipro for anyone 18 and older you can use. Or they can take rifampin too. That's fine. But for children, it's going to be rifampin. Aseptic meningitis, most cases are due to viruses, particularly enterovirus. We'll talk about West Nile tomorrow. Don't forget lymphocytic choriomeningitis, and we'll talk about why on tomorrow. But remember, this is with the hamsters. Lymphocytic choriomeningitis at the hamsters, and then herpes. You always think about someone with an encephalitis too. The chronic ones, these are all seen with HIV. We've talked about all these. So last little things occasionally show up. They sometimes have this kid who's lives on a farm and he swims in the cow pond. Okay, amoebic meningitis. You know where the latest cases have come from here in the States? We've had like 3 or 4 cases now. You know those neti pots that people use? They use their tap water and they use the neti pot, and their tap water has amoeba in it. So those of you that are doing that, please use distilled water or something not from your tap. So the cases, so I wouldn't be surprised if neti pot shows up. If someone's using neti pot and they got amoebic meningitis, okay? So don't swim in a cow pond. Don't use a neti pot from a cow pond water, for sure. All right. TB meningitis, class C, you'll have a 6-nerve palsy. That can be a clue if they ask that. And then Lyme, don't forget that Bell's palsy, okay, that we talked about. So they have isolated Bell's palsy or a foot drop. Think about Lyme. Okay, brain abscess, CAT scan is still good for that. Today, what you want to do is a stereotactic biopsy. Okay, you want to go in and have the neurosurgeon do a stereotactic biopsy to help you figure out what the organism is. You don't do an LP in someone with a brain abscess. Depending on where it is, you can kind of get maybe some help from the organisms, but pretty much they're all the same organisms, right? So that doesn't really help a lot. If they've had a neurosurgery procedure, then you worry about MRSA. The key thing is drain it if you can, and then put them on ceftriaxone and metronidazole. And vancomycin if MRSA is suspected. All right, briefly, GI tract. We kind of talked about these already. So let's do a case here. This is something we haven't talked about. This is a 12-year-old boy who's got underlying liver disease. He goes swimming in the Gulf of Mexico in Galveston. He's scratched by the animal on this slide. He develops lesions on his leg, quickly goes into DIC, and has liver failure. What is the most likely etiology? Does he have cat scratch fever, crab scratch fever, Vibrio cholera, Vibrio vulnificus, or he's got some disease from swimming in the Gulf with the dog? So what do y'all think? Okay, excellent. So this is vulnificus, okay? And for some reason, it's seen in people who have underlying liver disease. So, more likely we'll see in adults, but occasionally they'll throw a kid case on you. So just remember, and it's someone who has contact with seafood or some type of fishing or something, and it's always the Gulf of Mexico, okay? So something with the Gulf of Mexico, come in contact with crab, or they're fishing, and they get infected with this organism, and for some reason with the liver, if you've got bad liver disease or something going on with that, this organism is the problem. Okay, Vibrio vulnificus. The Vibrio cholera, remember, is a diarrhea that occurs. That's pandemic still around the world, but not here in the United States. All right, so just briefly on that, Vibrio. So the cholera is the pandemic. Occasionally you can see cholera here in the States from people who eat raw oysters. So occasionally there's outbreaks with raw oyster beds. So just be aware of that with diarrhea. But the vulnificus is the one that gives you the skin infection, sepsis, and the chronic liver disease. Don't forget the things that cause GI as far as fecal white cells. They may ask you about that. They say they've looked at fecal white cells in the stool, and they're positive. Just know it's got to be an invasive bacteria, so Shigella, Salmonella, Campylobacter. The big thing with Campylobacter that I'd remember with it is people who get this, they have an increased risk of having what neurologic disease? Guillain-Barré. Okay? Guillain-Barré. So Campylobacter is the most common predisposing organism to cause Guillain-Barré. Okay, C. diff. We need to spend a couple of seconds on here because we have new guidelines, and most people are, especially if they give you an adolescent, they may be trying to get you to know about this. So remember before, for C. diff, we always, it was just you use metronidazole first, right? And then they have a recurrence and use metronidazole again. I mean, it's just like a standard reflex answer. I use Flagyl, and then they get a recurrence, I use Flagyl again. All right. Now what you need to know is, for C. diff, is you need to look at how severe their diarrhea is. So if they have mild or moderate, and by that they define, you do a CBC, and their white count's less than 15,000, and their creatinine, so they have normal renal function, then you're going to use metronidazole. If, however, they have an elevated white count or they have renal insufficiency for age, you're going to use vancomycin. Okay, and that's a change. So they may ask you about that. Okay? If it's complicated, if they have hypotension, shock, or whatever, you're going to use vanc, but you're going to even use a higher dose. Okay? Which I don't think they'll ask you about that. And then but here's the big deal. So the first recurrence, which you know they're going to have, 30% of people are going to have recurrence no matter what you use. So in the mild to moderate people, we use metronidazole. If they have recurrence, we're going to use metronidazole again. In the severe group, if we use vancomycin, and now they have a recurrence, we're going to use vancomycin again. Okay? So whatever drug you use the first time, you're going to repeat it the second time if they have a recurrence. I've listed for you what you can do with severe recurrent relapses for those of you that have problems with this in some of your hospitals. Usually more of an adult problem, but occasionally you'll have problems in a facility that's got kids in it, long-term care facility. So those are there. I don't think the test will ask you about that. Okay, enterotoxigenic E. coli, the traveler's diarrhea we talked about. So remember, you can just give the antibiotic at the first sign of diarrhea. Let's do this case here. 20% of a cruise ship's passengers develop a moderate self-limited diarrheal illness. It's not associated with eating any particular food. The water supply is not contaminated. No raspberries are eaten. The seas are calm. The only nausea-inducing aspect of the trip is that Donnie and Maria are having a reunion show on board. What's the most likely cause of the outbreak? Is it rotavirus, norovirus, formerly known as Norwalk, Salmonella, there must be an iguana on board, Cyclospora, they're lying about raspberries, or is this hepatitis A? So what do y'all think? Excellent. Okay, good. So even though it's pediatrics, if it's a cruise ship, so if, maybe they'll have they wouldn't put Disney on there. That Disney would sue the American Board of Pediatrics for every penny they had. But remember, cruise ship outbreaks is this norovirus thing. Okay, so yes, rotavirus in pediatrics is overwhelmingly the problem, but on a cruise ship, look for norovirus. Okay, now if the whole cruise ship is not infected, so let's say they're at some buffet somewhere. All right, there's a buffet on the cruise ship, and only 3 or 4 people who eat at the buffet get sick. Then what do you think it might be? Like Staph Aureus food poisoning, okay, more of like a food poisoning thing. It won't be, it's not a cruise-wide diarrhea. So it's going to be, food left out, mayonnaise left out or whatever, and people get staph, toxin, or they get B. cereus toxin. So good. All right, so rotavirus, severe in infants, bad for parents. Norovirus is the cruise ship diarrhea. Don't forget that. All right, treatment. So they may ask you what's the most cost-effective test you can do on a stool, fecal white cells, yeah, whatever. But on the boards, that's probably the right answer. So look for fecal white cells. And then you're going to do cultures, generally, if you're worried about Shigella, things like that. Remember, Salmonella we don't treat unless they're severely ill or in infants less than 3 months of age. Asymptomatic bacteriuria, who do we worry about? The evil pregnant woman. So they give you a pregnant adolescent who comes in, and for some reason, you had a nurse to take a urine on her, okay? Or let's say you diagnose her urine pregnancy test, and they went ahead and ordered UA for some reason, and she's got asymptomatic bacteriuria. You would have to treat her, okay? So asymptomatic bacteriuria is always treated in pregnant women. You're obviously a neutropenic patient. The one that fell off of here, you notice, is no longer here is diabetics. So we used to treat diabetics with asymptomatic bacteriuria. We don't anymore. They don't have any increased risk compared to the regular population. If they ask you about common nosocomial infection in a regular children's hospital, it would be UTIs. Osteomyelitis. Okay, most common thing is going to be Staph Aureus, Staph Aureus, Staph Aureus. Okay, except if you get into a few things. So a neonate, remember we worry about group B strep here. And again, you can get Staph Aureus, but group B strep. If it's an IV drug abusing adolescent, Pseudomonas MRSA, the puncture wound through the tennis shoe, and then sickle cell patients, the number one thing is Salmonella. So pick Salmonella. Come argue with me later. Everyone agrees it's Salmonella except some of your old attendings who haven't read the new literature. So just pick Salmonella, though, for the test, okay? And it's the right answer. Sickle cell patients, most common cause of osteomyelitis, Salmonella. Number 2, Staph Aureus. All right. If you do a bone scan, if it's negative, then you know you don't have osteo, okay? You know you don't have osteo if the bone scan's negative. Remember, plain films, it takes 10 to 14 days. You'll see periosteal elevation. They may say, oh, there's this draining wound, and we did a culture from it. Does that correlate with what's down in the bone? The answer is no, okay, unless it's Staph Aureus, which remember, it's Staph Aureus, Staph Aureus, Staph Aureus. So if it's there, it's fine. But it's not. You don't want to drain. I mean, don't culture the sinus drainage from the wound. It's not going to help you any. And if for some reason a kid's got a prosthetic joint, Staph Epi is what you worry about. Treatment, IV antibiotics in general for 5 to 14 days. And then in kids, what's cool is we can switch to oral antibiotics. Okay? So acute hematogenous, you can use IV initially and then switch them to oral. If they've got a septic joint, though, you're going to drain it and need IV antibiotics.